2 of the OEBB board meeting. So first on the agenda, everybody should have access to the entire document Rose sent, is the approval of the minutes from December.
Move to approve.
Second.
Rose, did you get that?
It was Bob.
Okay, Bob. Thank you, Bob. All right,
Yep.
all in favor of accepting the minutes as written, say aye.
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 Any nays? All right. I do want to back up and do a roll call real quick since I failed to do that. Tom is here. Bob is here. Reed, were you able to make it? Reed is stuck up in Alaska right now, so I didn't know if she's going to be able to get to a space where she could actually join in. Susan Miller? Nope. Susan Reiki Smith? I saw you. Bonnie?
Here.
Oh, Susan Miller's there. I see her. Bill is here. Jeff's here. JJ. Does anybody see JJ on their screen? No. Okay, so we have 2 missing, and maybe they'll join us later. All right. So first up on our very packed and eventful agenda is Ali with the director's update.
Thanks, Robert. I was able to get logged in. I hope everyone had a wonderful holiday season and maybe even saw some snow. I just wanted to give the board a quick update on the Omicron variant. A lot is happening as we all kind of get back into our professional workplace, and the Oregon Health Authority is obviously no exception. So actually, through the month of December, we were planning on how to staff a return to the office as state agencies were reopening January 3rd, and about the time we had kind of reoriented staff to coming back into the office, the Omicron variant hit, and we are now back remote for the foreseeable future, and which is fine. I mean, staff has done really a great job working remotely, and but regarding the Oregon Health Authority, I'll learn more at an OHA leadership meeting tomorrow, but there are some things that may happen. Just wanted to make the board aware. We could be put in another kind of all hands on deck moment as an agency where all employees are asked to work towards getting us through this pandemic phase. So this would be similar to April 2020, when basically all committee and work groups were temporarily put on hold, like CIAO and the innovation work group. The board work would continue. Again, I should have a more definitive direction tomorrow, but that's the early word. Basically, the reason they look at committees and work groups from our perspective is not just staff's attention directed to this work, to the pandemic work, but even our partners like carriers and those organizations as well. So you'll be hearing from our carriers shortly regarding the spread of the variant. And I know there's a lot happening right now in our school districts and mitigating the spread. But I just wanted to give the board a quick update on what's going on with staff and our agency. And hopefully this variant will run its course fairly quickly and without the number of hospitalizations and deaths we've seen from the Delta variant. But at this point, we'll know more later this week. And that's really all I had today, Robert.
Okay, great. I've got Sue and then Tom.
Yeah, please go ahead.
Yeah, thank you, Robert. Ali, given what you've just shared, do you have any sense relative to the RFP work that we are doing, whether that it will be suspended for a period of time or whether that will go forward?
That will go forward. That is considered critical, as is the board work renewals. Mm-hmm.
Okay, thank you.
Yep.
Good question. Tom.
Yeah, the issue just has to do with CIAO. If CIAO is going to be put on hold, we do a lot of the prep work for changes that are associated with the renewals. So you may need to increase the length of the board meeting a little bit if CIAO is going to be put on hold.
Yeah, that's a great point, Tom. I'm hoping we don't have to put it on hold. I know that that's what we were asked to do last time. And hopefully this will be a much shorter period of time that we would have to take drastic measures. But
no, I get it.
yeah.
I'm just saying that you do what you have to do, but if it's it may implicate just a little bit, may need to expand the board meeting a little bit if you do that.
Sounds good.
Any other questions for Ali? Okay, we're going to move on to the Moda 360 update. This is one that I unfortunately cut last time, so we wanted to make sure that we put Erica up front this time because she was so patient with us.
Thank you, Robert. Rose, do you want to? It looks like this deck should be back. Or maybe you have the a deck that didn't include it. I don't know if that got sent out though. There we go. Great. Thank you, Rose. And thanks for letting us provide an update on the Moda 360 program. We provided the same update to CIAO a couple months back, and we're really providing an update on how Moda 360 has been going over the first year. As a reminder, we implemented this program 10/1 of 2021. So we now have a whole year of experience with the program. So I'm going to start off and talk about our Health Navigator team, what they've been doing, as well as how the point solutions have been going that we implemented as part of Moda 360. And then I'm going to pass it to John Klaus, who's our Chief Data Officer. And he's going to talk more about what we've been doing and what we are working on moving forward around our data strategy. So let's go to the next page or slide, I guess. Thanks. So as a reminder, Moda 360 is really a non-traditional customer service approach. It's really aimed at helping members get out of the middle. And we do this through a few different ways. One way is through a new technology console that our health navigators are using, and this allows them to be able to support our members better, help anticipate their needs, and then connect them to the resources that are right for them. Our health navigators who are really doing that job and helping navigate our members. And we are also engaging members in the right programs for the programs that are right for the members. And then with this new year, 10/1/2022, 10/1/2021, my years are all getting mixed up. We implemented this 10/1/2020, and the new year started 10/1/2021, which is when we integrated dental into the Moda 360 platform. Next slide, Rose. And now I just want to give an overview of what our health navigators have been doing this first year. So as you can see, our navigators have been answering a whole lot of calls, and they've also been making a lot of outbound calls as well. And this is something that's different for the health navigators. This is not something that you would generally see in a normal customer service approach. So our navigators are reaching out to providers to help members navigate through those situations. And then they're also making outbound calls to members to assist them as well. They're also sending emails to our members. This can often be as a follow-up. So for example, if a navigator has worked with a member on a situation and maybe they talk to them about a program that they think would be good for them, they can follow up with the member, provide a summary of their conversation, and then also links so the member has an actionable takeaway to enroll in that program. We rolled out a chat feature on August 28th. And so from August 28th through the end of the plan year, which was 9/30, our navigators had received 283 chats from members. And so we are continuing to see this expand as well. So when members are in their dashboard, they can just click on a little icon inside of their dashboard and be directly connected to one of our health navigators. Right, next slide, Rose. And after each interaction with a health navigator, we do ask members if they'd like to take a quick survey just to let us know how the navigators are doing and if there's anything else that we can do to help. And so from the results of those surveys, and at the time that I pulled this together, we had received 966 surveys. 92% of our members said that they were satisfied with the way the health navigator handled their call. And then 99% of members said that they were satisfied with the knowledge of the health navigator. So we're hearing a lot of really good feedback from members. And Rose, if you go to the next slide. And this slide really shows some of the feedback that we've received from our members, because I can tell you what our navigators do, but to really see the value and the way that they're impacting our members, it's really helpful to see the comments that we're getting. And these comments are coming in, some of them come in from the member surveys, but a lot of them are just emails that members or phone calls, voice messages that members are sending to us after they've had interactions with our health navigators. And I put some comments here, but there's actually one that I wanted to read to you. And it's an email that we received from a member here recently. And so this member said that they worked with one of our health navigators and they helped them through a very difficult time when they needed to find care and help to support their daughter. So they found the navigator to be very professional, caring, helpful, and supportive, and were truly blown away by her follow through, clear and kind communication, empathy, and ability to help their family in the crisis situation. She says, over the years, I've had interactions with healthcare representatives at all levels, and she's never received any service or attention like the personal care that this navigator took in helping her. She said she's truly grateful and in awe of how she handled their needs. What an asset we have on our team. And then she also went on to give another 2 big shout outs, because this member had actually called in with a couple of issues. And so she actually worked with a couple of our other navigators, and she wanted to give shout outs to them as well. And she said that they were both exemplary in their patience, kindness, empathy, and help in getting the answers that they needed, truly above and beyond, and told us if we were to play back their calls that we would be incredibly impressed. She went on to say that all 3 of those ladies, she could hear the care and concern in their voices. She wasn't just a call to get through, and there was so much kindness, understanding, and patience, so much follow through, and she knew that she could trust the information that they were giving her and that they actually helped her navigate through her issues, which she said were not easy issues to navigate through. So just an example of some of that feedback that we're getting, and it just shows that the navigators, when they're working with members, they're helping make the situations easier, because in a traditional model, you know, our customer service reps will give information to members, but our health navigators really take on the charge of doing a lot of that legwork themselves. So they're reaching out to the providers, and they're working between the providers and Moda, because they know the right questions to ask and the right next steps. Where members, when they come into this, it's often the first time that they might be dealing with an issue, and they don't always know where to go next. So really excited to hear the feedback that we've been hearing from our members this year. All right, next slide, Rose. And if you have any questions, please do stop me as I go through. One of the things that we implemented in our member dashboard on October 1st of 2021 are care reminders. Now, care reminders are something that already showed up in that new technology console that our navigators are using. And what these are is they are reminders for care for certain services. Most of these services are tied to the quality measures that we have in our contract with OEBB, and also in our contracts with our providers. And they're usually preventive measures, such as, you know, the annual wellness screening, well child visits, flu shots, and also care around diabetes. And so on 10.1, we now have these showing up in our member dashboard. So when a member logs into their member dashboard, on the home screen, they're going to see any care reminders that they have. So this is an example of a care reminder for statin therapy for diabetics. And here you can see it allows the member to be able to clear it if they've already done it, and maybe our records just haven't been updated yet. And then it also lets them contact a health navigator. And then if they click that live chat button, then they can reach out directly to a health navigator if they have questions about the care reminder, or if they need assistance in scheduling an appointment or knowing what that next step is to help with that care reminder. And I've been really excited to see the engagement so far in the member dashboard with these care reminders. So this is for only 2 months. I was able to pull the October and November data for this. And the majority of people are saying that they've already done this, which is fantastic. And then the second next highest engagement that we're having with this is visit a dentist. So if a member hasn't had, if we have, our records are showing that they have not seen a dentist in the last 12 months, then we'll put up a care reminder, reminding them of that. And so members are really engaging with that care reminder. They're also engaging with the cervical cancer screening, breast cancer screening, and antidepressant warning care reminders as well. So I'm excited to see how they continue to engage with this when we have some more months of data to look at as well. Next slide, Rose. Right, so now I'm going to go through our point solutions, and I'm going to just give a quick overview of it and then give an update on the engagement that we've seen with the point solution over the year. And I'm going to go over these just a little bit quickly so that we can get to John, because I know we don't have a ton of time to go over this, but please do let me know if you have any questions. So the first point solution is Maru Health, and that's a 12-week online program that addresses anxiety, depression, and burnout. And this benefit is billed at the normal cost sharing for the first initial assessment for members. And then after that, the 12-week program is at no member cost. Next slide, Rose. And over the past year, we've had about 992 members sign up. Of those members, we've received baseline data on 207 of them. 557 have completed the diagnostics. And then we have 228 members who were in progress when this was pulled. This chart over on the left shows the engagement throughout the year. And so those spikes you can definitely see are corresponding to a communication or outreach that we have done on the program as well. Next slide. And one of the great things about the Maru program is that it provides outcomes data for the members that engage in the program. So for last year, there were 383 that had completed the program by the end of the year. More were still in progress, by the end of the year, but 383 had completed. And they do the PHQ-9 and the GAD-7 screenings. And you can see here that there was a pretty good decrease in symptoms throughout the engagement in the program for members, with an average symptom reduction of 52.6%. And Maru is also reporting that 239 were treated to readmission for the program. Next slide, Rose. Another point solution was Cirrus Md, and this is a text-first telehealth app that provides access to a provider 24/7 and nationwide. So members throughout the entire United States can use this service. It has no member cost share, and it allows, and providers are also able to write prescriptions. So this is a good tool for members to be able to use for a lot of different reasons. One reason is if they have, a quick urgent need and they can't get into their PCP right away. And then also for members who may not be engaged with PCPs. I think of the young adults, age 19 to 24, often are in transition, going to college or moving, and maybe don't have that established PCP or are trying to find and establish themselves with a new PCP. This can be a great tool for them and can keep them out of the urgent care or the ED for reasons that may not be necessary. And I always like to give the example of the pink eye. I know I've said it to you guys before. And as being a mom who has kids who get pink eye, or used to, they're older now. One of, it's like, your kid has pink eye, and then you call your provider and you have to wait all day or till the next day to get in. But it's pink eye. And with Cirrus Md, they can actually diagnose that and prescribe the little eye drops so that you can help get that cleared up faster rather than waiting. Next slide. And this shows the utilization of Cirrus Md throughout the year. Total, there were over 1,100 members that used Cirrus Md for the entire year. And the chart on the right shows the resolution after the appointment. So there were about 30% of the members who had in-person follow-up after using Cirrus. A very small percentage had a virtual follow-up, with the majority of the members reporting that their issue was resolved using Cirrus Md. All right, next slide, Rose. Then Livongo. Livongo is our diabetes management program that combines advanced technology with coaching to support members with their diabetes. This program is really great. It's no cost to members. And then it includes a lot of different things. It includes a smart meter that provides real-time tips and automatically uploads blood glucose readings. So when a member pricks their finger, and tests their blood, that reading automatically gets sent to Livongo. And then based off of that reading, maybe it's high or if it's low, Livongo will send a tip based off of that reading to the member right then that just helps them understand how to manage that reading. Livongo keeps all of those readings, and a report can be produced that the member can keep or give to their PCP to show how well their blood sugars have been managed throughout a time period. And then also, if a blood sugar reading is out of a certain range, then Livongo will actually alert the member, their family, and their PCP of when those readings are off. And then members also have unlimited free testing strips and lancets, and that get shipped directly to the member. And so this can be ordered right through the app when a member needs to refill those. And there's no limit on the number that they can order with that program as well. And then members also have access to coaching with certified diabetes educators. And this coaching is available through phone, text, and also through the mobile app. So next slide, Rose. So this is showing the enrollment that we've had with Livongo for the OEBB population. Right now, we are seeing about 20% of our diabetic members engaging with the program. And this is really just a start up for the program. We do anticipate and expect that the engagement in this program will continue to increase. And we do continue to reach out to members who have not yet signed up for the program or engaged. And then as we identify new members as well, because we're always going and looking through our data to identify if anybody else meets that criteria. Livongo also provides some outcomes data, and they're showing that for that year, the change in estimated HbA1c was negative 0.83%. And then they also show over here on the right, the engagement with the program. So the device monitoring, as well as the different coaching that they offer as well. And we will be doing a more in-depth analysis of Livongo and how that has worked for our members for this past year. And we are just waiting for some additional time for claims run out. Next slide, Rose. All right, I have two more programs to talk about before I pass it over to John. An exciting program that we launched in July of 2021. You might remember us talking about this at our last renewal, but we were able to implement this earlier than October. And it's a program that focuses on helping members adhere to their diabetes and blood pressure medications. And the way it works is Sempre, which is the name of the company, they will send a text to members reminding them of their medication that needs to be refilled. And they can also even submit that script to the pharmacy so that the prescription is sitting there waiting for the member when they pick it up. When they go to pick up the prescription from the pharmacy, if they get a discount on their cost sharing. And the more that they adhere to their prescriptions, the bigger the discount becomes. So over time, their discount will continue to increase. So we've only had an experience for a few months with this program, but we're already seeing some really great savings associated with it. And we had at this time 393 members enroll out of the about 2,200 eligible. So I do fully expect that to continue to increase. The average member discount per fill was $60. And then the total member savings just from that time period was almost $46,000. When looking at the adherence rate for the members who were enrolled in Sempre, they're showing 78% compared to 56% of the members who did not enroll in the program. So it'll be exciting to continue to watch how this progresses after we have a whole year's worth of data as well. Next slide, Rob.
It looks like Erica has experienced technical difficulties. I don't know if we want to, this is Katie, apologies, move forward with John. Oh, are you back, Erica? There you are.
Can you hear me?
Yes.
We can now.
Yes.
Okay, sorry. I don't know how long I was out for. So
It was
hopefully-
a petit mal seizure. Just a short
Oh.
one.
It's weird when you don't even realize that you're the one having the the issues. All right. Well, thank you for letting me know. I'll continue and hopefully it doesn't happen again. So we launched our Moda 360 Advanced Imaging Steerage Pilot Program, and this was one we also talked to you about at our last renewal, but we're able to implement early. And the way this program works is that members who we receive a prior authorization for a facility that is high cost, then we reach out to them and let them know that they could save money if they went to a lower cost facility. And we use our health navigators to do this program as well. And so when we get that PA, we will instantly send them out an email letting these members know, and it also lets them know the estimated amount of their savings. And then our health navigators will follow up with a phone call as well. Next slide, Rose. And actually, let's skip out to one more slide too. So with the program, we identified 513 members that we thought we could try and move to a lower cost facility. And then as we looked at those members, we were able to call 144 of them. We were able to reach 70 of them, and then 20 members switched. And this is because it was a pilot program. You know, we started at the beginning and started tweaking around some of the approaches, trying to find the best way to be able to reach members. And some of the things that we learned was first, sending the email in advance was much more efficient. At first, we just tried calling members, but we realized quickly that one, members can be difficult to get a hold of. And two, it's a timing issue, because sometimes that prior authorization for that imaging procedure, we don't get it until the day before the appointment is scheduled. And so the email, when it automatically goes out, helps some members be able to see that earlier rather than later. And we also learned that members really appreciated the information, even if they did not make the switch. And sometimes they didn't make the switch just because of the timing issue. And we were able to successfully, our success rate since the summer when we implemented this program was 36%. And the average savings per switch was $1,700. And that savings is a combination of both member savings and the plan savings. So from that, we are continuing with the program, and we have expanded that now to more geographies. So now any member in any geography that gets a prior authorization for one of those high cost facilities, we are reaching out to talk to them about switching. All right, next slide. And so now I'm going to transfer this over to John. Sorry, John, but just wanted to check really quick to see if anybody had questions about any of the information that I presented. Fantastic. Well, thank you very much. John?
All right, thanks, Erica. It's a great setup talking about the health navigator role and the point solutions. And what I'd like to do is talk about some of the investments that Moda's made behind the scenes into the system supporting those pieces, and our future path forward to improve member engagement. So I think that image steerage example is a great one. Not only is it a great administration of a program, starting with a pilot and engineering improvements along the way and continuous improvement, but inside there, you kind of recognize some of the things Erica was talking about in terms of how people like to be contacted. What's the most successful way of getting a hold of each individual member? That's all part of something that we refer to as customer relationship management. And that's a big piece of Moda 360. And I think there's a fun story about image steerage where we're getting a hold of people, the message is resonating. There's a call that was made and we're talking to the member. and presenting them with this lower cost alternative as they're sitting in the exam room waiting for the procedure that they're about to get that was higher cost. So being able to identify how best to reach members and the most effective way of communicating with them is part of customer relationship management. Understanding the member as a person and not just a patient is health context. And I think we've talked about health context a couple times in this group, but it's worth kind of maybe taking a step back to talk about this, and then we'll walk into more on customer relationship management and the investments we're making to support the point solutions. So when it comes to identifying members in greatest need, or being able to identify the optimum mix of point solutions, or finding the resources or the solutions that are available and the right fit for a member. On the provider side, we might have perfect clinical information. And on the payer side, we might have perfect claims information. But neither of those are sufficient. We really need the social determinants of health that describe the lived experience of those members in between encounters with the provider. And so at Moda, from the beginning, we built the Moda 360 platform based on health context, which is our expanded view of social determinants of health. So if we go to the next slide, Rose, we'll start to see how health context fits in with customer relationship management. And so over the past year, we've been working on building out a new version of the console that our health navigators use to help in their service to the member. And we're now working on a new console, a new dashboard that our members will be able to interact with directly. And then both of these are built on the same platform so that we have a longitudinal view of the member. The health navigator or the member can see all of the interactions they've had and help establish some context and allow us to answer their questions more succinctly. The key here, and Rose, if we go to the next slide, is being able to create that single view. What's happening at primary care, what's happening with a health coach, and now with the integration of point solutions, we still need to be able to provide a comprehensive view, even if they're engaged with Livongo, Maru, Cirrus, Strive, and any number of these solutions. So we have spent a long time integrating that data from Livongo, improving the data we get from Maru, and then just in the last month or so, Strive for chronic kidney care and Sword for physical therapy. So the Moda 360 platform provides a comprehensive view of the member. It integrates the information we have from providers and third-party solutions. And then in the next slide, what we're doing with that is trying to be able to differentiate members who look the same clinically, but have very different experiences. Everyone that's in Livongo had the same clinical diagnoses, but some of those members are going to be successful and other members will not thrive. And so it is the health context that helps us to understand what characterizes success inside of a program like Livongo or Maru. What's characterizing a group that's not a good candidate for these programs, and maybe more importantly, what members are in a group that's almost ready to thrive, but a barrier exists. And if we can help remove that barrier, those members are likely to succeed in that program. And so the interaction of that health context information, our claims data, the integrations of the point solutions, and our health navigators' conversation with our members are all supported by having all this on one platform. And then if we go to the next slide, in order to really improve member engagement, one of the fundamental principles is around personalizing the information. So knowing not just who the patient is, but who the member is, and then what are they eligible for, what are they enrolled in, how are they doing, and what could we tell about them that allows us to help identify the right mix of these point solutions supporting their primary care provider and the circumstances that they're living in. So that personalization is around understanding what segment a member might be in, what risks they might be needing to address, and where they are in their care plan. So the last step here in the last slide is around taking all of this information and incorporating it into machine learning models, artificial intelligence, so that when we see a member, we have insights into where they're at, what might be the optimum mix of point solutions for them, and when they call and reach out to us, or when we call and reach out to them, and we resolve the issue at hand, what then might be the next best action? What service might we be able to offer that member? What intervention might help them improve their healthcare outcomes? Or what might be the next best thing based on what we know about them as a patient and a person to improve their member engagement? So that's a quick update on our intersection of Moda 360, the customer relationship management platform, and integrating the health context into that platform and building out our AI engines to create actionable insights for our members.
Thank you for the presentation. Any questions at all? I thought it was very informative. I appreciate it, and I appreciate the patience once again. So,
Okay.
Thanks, Robert.
Anything else, Erica?
No, that's good for Moto 360. Thank you.
Okay.
Thank you all.
Well,
I had a quick question, Robert.
Yeah.
So you're talking about coming up with these insights. Are you sharing it with with those insights with the people who are actually providing care to the member, specifically feeding back that to the PCP 360?
Yeah, we've been talking about the member-facing console. We've been talking about the Health Navigator console. That work is underway and is our current focus. The next phase after that is to set up a provider console. And right now, there might be ad hoc in a connection with that provider, but what we're looking to do is be able to give the provider access to the same platform to support a more direct conversation. And you're on the right track. What we'd love to do is say, based on what we've put together, here are the insights. And we'd love to be able to tee it up so that it's not a classic population health tool identifying, gaps without providing a means of resolving them, but saying, hey, based on what we know of the health context for these members, they're a great candidate for maybe it's a Livongo, a Sempre, and a Maru. And there to be able to have the provider decide that, yes, that's a good fit, and then click a box to issue an invitation on behalf of the provider to those programs, or to provide context that the patient is eligible for those, and that the provider could send a recommendation to pursue that.
Thank you.
Okay, anybody else? All right, so we're going to move on to COVID updates from Kaiser and Moda, and then we'll switch over to the renewal strategies for 22-23. And it looks like for the first update, it's going to be you, Erica, and Dr. Popowich.
Yep, thank you. This is Dr.
Yeah,
Dr.
and actually, sorry, just to kick off, it's actually going to be Katie Schiller from pharmacy. Yes, sorry, the agenda was not updated, and by us, I'm sure, and then Dr. Popowich as well. So can we go to the next slide, Rose? There we go. And then the next slide as well. And Katie, are you on? Because we are going to start off with pharmacy.
I think we're at the part of the agenda for the COVID update. Did I hear that wrong?
Yes.
Oh, sorry.
It's the COVID update, so we're on the wrong track.
I'm so sorry.
Yeah.
I mixed it up. Dr. Popowich, you should have just told me to be quiet. Dr. Popowich will take over the COVID update.
It's fine. So good afternoon. I'm Dr. Popowitz, Chief Medical Officer here at Moda. I'm going to give you our COVID update. So as of this week, the CDC has reported that 242 million people, up from 215 million, have received at least one dose of a COVID-19 vaccine, with 206 million fully vaccinated. 68 million, or 33% of fully vaccinated, have received a booster. In Oregon, 71.4%, up from 67% of the total population, has received at least one shot, and 65%, up from 61% of the population, is fully vaccinated. Nationally, we're looking at 53,795,407 cases and 820,355 deaths. Probably what's foremost on most people's minds, with what started out as a whisper just a few weeks ago, the Omicron variant has now built to a tremendous roar. In this past week alone, the U.S. is reporting the highest 7-day average of new COVID cases that at any point in the pandemic. And at least so far, this has not translated into proportionally higher hospitalizations and deaths yet here in Oregon, though the wave that has struck the Northeast and other areas of the country is certainly coming. There is optimism among scientists that this Omicron surge will be swift. In lab studies to date, Omicron has been shown to be far less aggressive to the lungs than prior variants, which likely explains the lack of a surge in deaths and hospitalizations with all the new cases. New oral medications from Pfizer, Paxlovid, and Merck, the Lagevrio, may offer some benefit to newly diagnosed patients if they're given within 5 days of symptoms. The data is scant, and these are by no means going to be the silver bullets that many had hoped for and initial reports had praised. At the end of the day, guidance is the same for everyone. Get vaccinated and boosted, especially with boosters available for most age groups now, including the Pfizer vaccine now available for 12 to 15-year-olds and even 5 to 11-year-olds who are immunocompromised. So I'll now shift over to our OEBB data. This is the most recent data from our vaccine counts that is derived from medical, pharmacy claims, and alert data as of 12/21/2021. Overall, 76.3% of all OEBB subscribers, down from 77.9%, have had their full vaccinations, and 23.9% have had their booster. This is down from October due to not having the claims history for newly enrolled members who joined on October 1st. We have many new members this year. In fact, it was close to 6,600 new subscribers and 9,000 total new members, including subs and dependents. So that accounts for why some of our numbers are trending a bit down. We should have these members accounted for at our next COVID update. The highest booster count seen in members who are 65 plus is at 38.9%, with other age groups slowly climbing. For the regional breakdown of those members fully vaccinated from highest to lowest, we see a lot of stability in our numbers. But again, a lot of these numbers are skewing a tiny bit lower than they were at our last meeting, again, because of these new members. Portland Metro, we're at 83.4%. Eugene, we're at 80.4%. Salem, we're at 81.4%. The Oregon coast is 76.5%. Central Oregon is at 73.6%. Eastern Oregon is actually one of the ones that has come up, which is nice to see, at 71.3%. And Southern Oregon is at 63%. Overall, there have been 5,242 members who have had a COVID diagnosis. This is up from 3,895. And overall, 227 members, up from 155, have been hospitalized with a COVID diagnosis. Overall, we've had 19 fatalities, and that is up from 11 at our last meeting. In terms of ongoing efforts, we are still ensuring members are informed of their COVID-19 benefits and know where they can access information about these benefits. We continue to partner with public health offices, again, especially in Eastern Oregon, where we saw a higher level of vaccination hesitancy and are happy to see that those numbers are coming up. We continue to have messaging to all members where we are continuing to encourage vaccination and providing assistance to unvaccinated members who are open to vaccination in terms of finding sites, transportation as needed. And that is my COVID summary.
Okay, thank you so much, Dr. Bachman and Sapari.
Okay, I will take that. I will concur with everything Dr. Popowich just said about the Omicron variant and its popularity and severe infectiousness. Just a couple other clinical notes to highlight there is that the incubation period does appear to be less than prior Delta variants, with incubation thought to be 3 days as opposed to 4 to 5 days for the other variants. So that does have implications for recommendations the CDC is making around contagiousness and isolation. The Omicron variant appears to be most contagious 2 days prior to the onset of symptoms and then 3 days after symptom onset. The booster is critical, and we definitely see increased immune responses and decreased positivity and decreased symptoms when somebody's had their booster. So I think doctors in the field are sort of talking about this as 3 sorts of diseases or clinical presentations that they're seeing for people that have had no vaccinations in the past with a much higher risk of developing severe clinical disease, hospitalizations, intensive care unit treatment, and death, people who have been boosted who are unlikely to have severe clinical symptoms, and the people in the middle who've been vaccinated who are likely to have moderate disease, but less likely to have severe disease. And this really resonates with what I'm seeing in clinic. I'm seeing more than ever positive tests in my practice, and with most people, relatively mild disease that really just needs reassurance. Vaccinations. Currently at Kaiser Permanente, 73% of our members have had their vaccine series completed. More than 1 million vaccinations were given by the end of the year. We still see geographic disparities with higher rates of vaccination on the west side of the metro area at 90% and lower rates of vaccination on the east side a little bit, and then Mid-Valley at 78%. We're increasing to see numbers of younger people starting their vaccine series. We're now at 39% of kids 5 to 11 and 64% of 12 to 15-year-olds and 70% of older teenagers. OEBB is rocking it. So OEBB subscribers are 92% completed or started their vaccine series, which is just phenomenal. OEBB members somewhat lower at 79.5%. With 2 to 3% additional members catching up per month. That's due to kids lagging behind related to the sequencing of the recommendations. We're seeing reduced disparities between races and ethnicities in the Kaiser Permanente population. By the year's end, comparing the vaccination rates in white Kaiser members versus Latinx Kaiser members, that rate went down from 14% early in the year and is now down to just a 2% variation. Among Black members, that numbers have gone from 17.6% variation compared to white down to 6.5%. We're currently running 16 vaccination centers around the region and offering all the vaccines that we're not starting anybody else on J&J. We are offering flu shots at the same time. We're also referring to OHA and county resources. Testing rates pretty dramatic, I would say. The number of positive tests in the Kaiser Permanente population are up 4-fold since a month ago. As of late December, when people had tests due to symptoms, the rate's now up to 23%. When I first started taking notes for this presentation last week, it was 16%. So that number of percent positivity is high. I haven't seen that in Oregon at all. Our hospital census is starting to increase compared to the last couple of weeks. We currently have 74 Kaiser Permanente members hospitalized. It is similar to last year at this time, and it's lower than the fall spike, but it's higher than last July. OEBB has had 6 to 7 OEBB members hospitalized per month over the last several months, which is lower than last winter, but higher than last summer. Bottom line, office practice changes in our offices that we think would be good in your offices as well, which are stay home and get tested if sick. Review the CDC recommendations regarding both quarantine and isolation because they are changing. We are recommending people really avoid break rooms and cafeterias where you have to be unmasked to eat, ideally one person to a table. Minimize that unmasked times. Use appropriate PPE at all times in healthcare settings. And we're also concerned that, which I'm sure you're worried about as well, with the increased number of ill healthcare workers or healthcare workers with positive tests is going to be causing staffing challenges in the near future. That's the update. Thank you.
Okay, we have Tom with a question.
The issue has to do with testing. There's the rapid tests that people supposedly can do on their own, but they can't get the tests because they're not available. And the other one is the PCR, which is my understanding is that the number of people requesting them is overwhelming the system, and it's taking more and more time to get results. Is that a fair assessment, or is that not what you're hearing? Keith, you can obviously respond for your system. Dr. Popovich, I don't know what you're hearing from other health systems that you're dealing with.
Yeah, I mean, one thing is the number of people with COVID and know they have COVID is probably a lot less than the reported data, since the only data that we have is the ones that are run PCR tests run through our lab. When people use we're certainly hearing lots about people using home tests that are positive after exposure or with symptoms, and that's not going to get reported in the public databases. Our turnaround time in the lab has been fine so far, and it's really, labs are coming back within 24 to 48 hours, usually more within 24. And I haven't heard about excessive delays in getting PCR tests. That's usually within 1 to 2 days for when somebody wants one. That could change if a machine goes down. If there's staffing issues, then we can't staff all the sites that we do the COVID swabbing. But currently, that's the status.
Yeah, and I'll add that PCR turnaround times out in the community hospitals has been a bit longer than it typically has been by an extra day or two. I'd also agree with Dr. Bachman that since so many people are self-testing at home, a lot of reporting is going to be underreported. So the numbers that are out there are going to be perhaps deceptively a little bit low, and that pharmacies are struggling to keep up with supplies of tests, of home tests.
Yeah.
Any other questions for either of the two doctors? Okay.
A question.
Yeah.
One of the questions that we were talking about a month ago was, how this impacts schools, and there was the concept of tests to stay. I don't know whether or not the schools are getting the tests to be able to do testing of their students.
Yeah, that's a great question, and I honestly don't know what the guidance right now is for the schools. I think for now, it seems schools are staying open, and that's certainly the case throughout most of the country, and certainly in the bigger cities, New York especially, that they want to keep the schools open as long as possible, as much as possible.
Tom, this is Sue Ricky Smith. I can answer at least for our area. We currently have enough Binex now that are in stock, but as students continue with the test to stay, we'll probably run short. I know that the state has increased and has ordered over 6 million kits, of which there are 2 tests per kit, and the preponderance of those are supposed to come to the school system. Additionally, we are part of OHSU's PCR testing program. And just as of today, with the first round of tests that students dropped off on a weekly basis on Monday, we have probably about 10% of those of all the total tests that are coming back positive just from Monday, and we anticipate that number is going to increase.
Yeah, so, amazing.
Yeah, we are much like healthcare workers. I think that schools in general are going to have their back against the wall here in pretty short order, in a very intense period of time. Yeah. Will not have enough staff to run, and then have to take a pause, and then move, and then get this and move forward.
Kind of like the travel industry, what they just went through or going through. With the exposure of all the people traveling over the holidays, the same thing will be. We'll hit. Yeah. Good luck.
Maybe we'll get lucky and have snow days at the same time. So.
Like about 5 weeks of it.
Robert, I've never prayed for that before, but I'm just about ready to. So.
Yeah. All right. Well, thank you for the updates. That was very informative. So next up before break, we have Willis Towers Watson and Jenny and Brad with renewal strategies coming up for next year.
Great. Looks like Rose is getting our presentation. Okay, good. A minute. Okay, good. Yeah, I love this this cover slide. I don't know. This reminds me of
Is it up?
Yes, it's up.
Okay.
Yep. Anyway. Okay, we're going to talk. We're going to get started. New year. You know, we were just talking about COVID, which is a super important topic, especially in the schools. But we're also busy at work planning on the renewal work for the OEBB board. So we're going to talk a little bit about what we've been thinking about, some early things for you all to think about, and then we'll talk about what's coming down the pipe in the next few meetings. So Rose, let's go to the agenda. Okay. So I'm going to take a minute or two just to review the goals for the renewal that we drafted last month. And then and then Brad's going to talk a little bit about how the OEBB plans have been performing over the last few years in the medical and dental, so that you can get a sense of how experience has been running. He's also going to talk a little bit about where we are with the rate stabilization funds. And then we're going to talk about two other concepts that we've said that we wanted to start addressing. And the first one is that ensuring sustainable rates by plan, and that means making sure that we have the right rates for each one of the plan designs. So we'll talk a little bit more about that. And then at a couple of meetings ago, we had shared some benchmarking about plan designs with the board, and there was some interest in taking a little bit of a deeper look at member cost sharing. So we're going to start that discussion today, and then we'll do some next steps. Okay, let's go ahead and dive right into the goals. So as I mentioned, the goals really are a continuation from the goals that were outlined last year with a few tweaks. So again, ensuring those sustainable and appropriate rates for each plan design. We are going to take a look this time at rate relativity. We'll explain more about that later in this presentation. The second goal is ensuring members have a meaningful choice of plan designs. And that, I think we are, to that point, we are going to talk about the member cost sharing and what's involved with that. And as in past years, the board spends a lot of time taking a look at plan design or program changes that can improve the underlying efficiency of the program or the plans. And those would include things like advancing coordinated care model efforts, increasing value-based reimbursements, and initiatives that develop either in CIAO or in the innovation work group, such as the Center of Excellence project that we're working on, or some behavioral health initiatives. A fourth goal is meeting the legislative cost growth cap of 3.4%, and then obviously also incorporating any legislative or mandated plan design changes. And then one of our newer goals has been to incorporate some health equity considerations into the decision making. I'll just pause there to see if there are any additional considerations that we should add to the list, or comments or questions. Okay.
Jenny, the only other one is that we need to apply the health equity. Oh, I'm sorry, I saw it at the bottom. Sorry, forget it.
Yes, yeah, health equity is definitely a consideration. So we've asked a number of questions about that in the renewal letters, and we'll definitely be talking a little bit about that during the renewal discussions this year. Okay, let's kind of move to our next section.
All right, very exciting medical and prescription drug trends. So we know at this time of year, we often like to take a step back and look at how the plans have been performing. And we'd like to look at that usually on a paid basis for both Moda and Kaiser. We know with COVID, this has been a challenge, so that similar to last year, we were kind of taking both a longer term look as well as a shorter look, shorter term look. And you know, you'll notice there's a lot of colored boxes on our slides this year. We've done that to kind of highlight a few things that have are either data points or that have happened through the course of the experience period. Kind of starting with the green box, which will have our longer term 5-year trend, as well as kind of the purple box, which will have a 3-year shorter term trend. And then we have our blue box that sort of is a representation of where our COVID claim suppression happened. And then finally, the pink box, which has kind of the point in time that the PCP 360 plans, as well as the hospital reimbursement cap, were both effective. So, you know, kind of looking at the green box and starting there, we see that trend over the last 5 years has been right around between 3 and 4%, which is less than market, which is great. And I also wanted to note that, you know, even after adjusting for that COVID claim suppression period, you know, we really didn't see much impact at all in our 3-year or shorter term look, really stayed right around the 4.1%, and then just had a very modest increase to the 60-month or 5-year trend. So we'll see that kind of as a theme as we go through here, where we've had enough experience and, you know, kind of where the COVID claim suppression happened in our time period here is not going to have a lot of impact on our trend measures. So kind of if we take a look at the trends separately for medical and pharmacy, we see that medical trend has been right around the 3% mark. Pharmacy trend over the long period has been between around 7 to 8%, but has been running a little bit higher in more recent months. Right, any questions there before we move on to Moda Dental? All right, so move on to slide 8. So here we see that, you know, for dental, you know, trend has been relatively flat for the entire experience period. You know, we also note that adjusting for COVID does not impact the shorter term trend and really only had a modest impact on the longer term 5-year trend. So, you know, very favorable results for dental, you know, even after adjusting for that big COVID claim trench that we see, you know, with the blue box there. The very good results. Right. Moving to Kaiser, you know, we see that when we kind of took a look at this, we really felt there was not a huge need to show a shorter term view. We looked at the longer term view. Trends have generally been, you know, very flat, as we see in that green box at 0.2%. And in fact, the shorter term trend, when we did look at it, was running negative. Although we do see, you know, in that kind of far right-hand side of the chart, we do see some volatility in the kind of more recent experience there. If we look at medical and pharmacy separately, we see medical's been running close to flat, while pharmacy has been trending negative. So, you know, again, very favorable results in the Kaiser plan. Any questions on the Kaiser? All right, we can move to Kaiser Dental, where we will see an even larger trench from the COVID claim suppression. You know, certainly that trench is driving a very large negative trend result. We see it's been running over negative 11%. You even adjusting for that COVID claim suppression period and kind of filling in that trench, so to speak, we're still getting negative trend levels. So, very favorable results on the Kaiser plan. Both running, negative over what appears to be both the short and the longer term. Any questions on that? Otherwise, we can move on to slide 11. And to sort of help put these trends in context that we've been seeing, we thought we'd show you a couple pictures of both a national, kind of some national trend measures, as well as a more local, regional, Oregon-specific trend measure. The chart on the left shows our national, trend study that we do at Willis Towers Watson, and you can see that combined medical and pharmacy trends before plan changes, which is sort of our upper blue line, has generally been running right around 5%, with the exception of 2020, which was, a significant COVID impact. So, definitely all of our plans are performing better than our national plans, national trends. And then we look at the right-hand side and we see that in the last year of our Oregon-specific insured carrier trend survey that we do, as of the October 1 plan year, carriers were generally averaging a combined medical and pharmacy trend of around 8.5%, which is significantly higher than we've been experiencing in either OEBB plan. So again, just giving a good indication that our plans are performing very efficiently and are doing very well compared to both national and local regional expectations. Any other questions there? All right. We can move to slide 13. And kind of as part of our renewal ramp up, we always like to take a look back at the current and projected rate stabilization reserve balances. For Moda, just as a refresher, we started the plan year with about $20 million of rate stabilization reserves, or RSR, as we love to call it. We did do a little bit of a buy down. We kind of adjusted down our renewal by 0.5%, and that's expected to take our RSR down by about 2.9 million, and roughly leaving us with about $21 million expected at the end of the plan year. We know that will be, could move up or down a little bit depending on enrollment in those plans. For Kaiser, we started the year out at 15.9 million. We are using 0.8 million for wellness space grants and on-site flu shots, as the board elected to do earlier last year. And that would leave us with a projected RSR balance of about $15 million at the end of the plan year. So kind of a natural question then that may come up is, well, what do we do with those funds and how do we spend them? And we can move on to slide 14, where we've outlined a number of recommended strategies and also a couple that we do not recommend. So our recommended strategies, really include managing to that 3.4% target, but by applying only minor changes and adjustments. You'll note on the not recommended side, we do not recommend significant buy downs of those rates or significant adjustments, and we'll highlight that in the next slide. Other alternatives could be, funding care management programs and point solutions that we expect to have a return on investment, or to fund pilot programs and or offer, value-added benefits such as our wellness programs and things. So again, the other one that we do not recommend is funding benefit enhancements. An example of that may be to lower deductibles or out-of-pocket maxes and fund that by bringing the rates back down with RSR. Any questions on that before we dive into our kind of fun illustrative example? I think it's always helpful because we don't look at this too often. So it's helpful to have a reminder of how using these funds to buy down our renewals can have an impact on the next year's renewal. In this example, we assume that we have a nice round baseline premium of $1,000, followed by a 3.4 increase, which would move us from $1,000 to $1,034 in year 2, and of course, that's a 3.4% change. So if the board had elected to buy down the current year premium by 2%, that current year premium would drop from 1,000 down to 980. Note that this does not impact the needed premium for year 2, since this is sort of just a buy down using those RSR funds. So our year 2 premium still remains at 1,034. And when we think about moving from our year 1 to year 2 under the buy down scenario, you can see that it's not a 3.4% change. It's really a 5.5% change. And so, you can see that if you had a really big buy down, that could result in a leveraged increase the following year that we would have to deal with and make up. So, while doing these small adjustments is good and appropriate, very cautious on using them for these large adjustments due to that leveraged increase impact. Any
Brad,
questions?
Oh,
yeah.
Yeah, sorry about that, Bob.
Hey, no
I
problem.
missed that.
Yeah.
Sorry, Bob.
Brad, I just have a question on, are you guys factoring in the cost of labor and that rapidly rising cost of labor and how that's going to impact the overall cost of healthcare and how that's eventually going to play down into our plan costs?
We do use a building block on trend approach. We partner with Moda and Kaiser on that. In particular with Moda, we really do look at those in how we project the unit costs. And when we do look at those trend rates that we get from Moda, we do then take those back and say, hey, how does this compare from our national perspective on starting with our baseline CPI and base medical trend and building up for things like aging, technology. The cost of labor would be one of those in there too that would be impacted. So far, I haven't seen myself in the short term, like for coming up in the new year, I haven't seen a lot of impact from salary increases in the medical field that would drive that. But that's a very good consideration, Bob. Did that answer your question?
Yes, it did, Brad. I was just curious because this is all kind of exploding in the last 2 or 3 months.
Oh, yeah.
So it's going to
Great resignation.
have an enormous impact over the next 3 or 4 years. And so,
Yes.
When Social Security is going up 5.9%, then you can only suspect that all labor groups are going to believe that their salary increases need to be similar. And I'm guessing the pressures are at least as equal, if not greater than in healthcare as in all other sectors.
Mm-hmm. Yeah, absolutely. Absolutely. Very, very good. Very good comment. And I think we have one more hand up.
Yeah, it's the issue. Just emphasizing what Bob is raising. When we've been able to skirt the 3.4%, mainly because we've had CPI between 0 and 1%, and how one deals with a 3.4% limit in an environment where let's say we have multiple years of CPI at 5, it's impossible without gutting the program, and it will be critical that the legislature addresses that issue.
Yeah, I completely agree. If we have sustained CPI of the 5%, I think we'll have a lot of issues in general. Yeah, absolutely.
Ali.
Yeah, thanks. Just a quick comment. Following Tom, the statewide cost growth target committee, the legislation actually allows for some considerations for things like inflation and other circumstances that would warrant an exception. There's a process to that, but it does allow for some wiggle room, whereas PEB and OEB's legislation does not. So hopefully, within the next couple of years, there will be some wiggle room for the boards.
Yeah, great questions. Good discussion. Are there any other questions or comments or thoughts on the RSR or increases or anything like that? All right, well, we'll move on to the next section, and it's going to be on slide 17. And this, as Jenny mentioned, we kind of wanted to discuss the topic of rate stability, and this is going to be through review of the current rate relativities. As a reminder, the board did review and set the rate relativities, I believe in 2019, when the PCP 360 plan lineup was, established. And during these discussions, the board agreed with Willis Towers Watson's recommendation to review the rate relativities again after about 3 years. We feel that's a time period that provides some level of rate stability. We went through quite a bit of rate restructuring at that time, and it caused a little bit of headache. So having 3 years of rate stability was a very favorable outcome. And 3 years is also a short enough time period, though, to not require, from an actuarial perspective, really significant differences or adjustments, on an expected basis to those rate relativities. So kind of balancing out the rate stability with, not going too long and not making large adjustments, say if you waited 5 or 6 years to do those. So, we thought we'd begin this discussion with kind of just a high level refresh of the rate setting process. In general, there's 2 main methods that are used to set rates. One is the experience method, and like it sounds like, you use the claim experience for each plan to develop the rate based on the claims utilization. This can, depending on the size of enrollment in the plan and the types of people that enroll in the plan and the large claim experience, can create a lot of volatility in those individual plan rates. In addition, it can create rates that may appear very, very low if you have a lot of individuals enroll in that are, either younger or healthier. And so it can create some migration risk if some of those less healthy folks look over at that plan and say, wow, that's really low cost. I think I might enroll in that. And of course, if a lot of people do that, then you have budget shortfalls in there. In the actuarial value method, that does not use individual plan experience to set the rates. We look at the plan as a whole and look at those claims and utilization as for the full population, and then rate each plan based on sort of the expected split between the plan and the member, and that's the actuarial value. So we look at this sort of the value of each plan is determined by its cost share components like deductibles and out-of-pocket maximums, as if the whole population were enrolled in that plan. So once we choose that primary method, we also then layer on incremental morbidity, which is quite a mouthful. And that really just recognizes that higher utilizing members tend to choose richer plans. And then we also have something that we layer on called induced demand, which recognizes the impact on consumerism that we often see in higher deductible plans. And then finally, plan sponsors can sort of use this discretionary plan steerage mechanism if they want to artificially steer enrollment into or away from a specific plan by adjusting those rates up or down. And we saw that sometimes early on in the HSA plan offerings years and years ago, where employers really wanted to encourage members to enroll in those plans. So any questions on that before we dive into sort of what our adopted approach was? And I will mention too that we have some information on each one of these things in the appendix if you want to dive in and sort of say, get a visual of what an actuarial value is, or we can go there if there's any questions from board members that may need a little bit more refresh on what that is. Sometimes those of us that live it every day forget that those who don't live it every day may be a little bit hard to follow or understand without an example. Okay, sounds like we're all up on it. That's great. There'll be a test later. Okay, so on slide 18, we'll move there. As we mentioned previously, the board did agree with our recommended approach, which uses actuarial value in combination with induced demand and incremental morbidity to arrive at our final rate relativities. I think much of this we've covered before, just has a few different words in there, but I think the key thing in there is that the board elected to not use any discretionary plan steerage, which we feel was appropriate because that plan steerage can result in migration risk and budget volatility. So currently do not have any of that plan steerage factors in there. All right, so following that on slide 19, we thought we would give an illustrative example of what a rate relativity adjustment could look like. So we did obtain new actuarial value projections from Moda. These actuarial value projections can vary tool by tool. They can vary when we update the claim distributions from years ago. They can change a little bit here and there. And as expected, we did have some level of change in there, but it wasn't really extreme in here. So our example assumes that a 3.4% renewal, we're just looking at the Moda plans for illustrative purposes. And that 3.4% renewal in the right-hand chart, you can see in the purple bars is really just flat across all of our plans 1 through 7. So when we update those rates and sort of redistribute our rates based on these new actuarial values, you can see that in the yellow bars, we do have some level of variation. I'll say most of the plans are less than 0.4%. So we are not seeing the big swings from 3% to 10% to negative 15%. Don't have any of those kind of swings. Most of them are very modest. We do have 2 little bit larger swings in plans 5 and 6 that are right around the 1% mark. And so if we want to kind of translate those percentages into sort of dollar amounts, we can look, we've got the monthly composite rates on the left-hand side, and you can kind of see what those differences might be in terms of dollars on a monthly basis. So looking at that plan 6, for example, we see that 1% difference is worth right about $13 of variation there. One final
so Brad,
comment.
I might just ask you a quick question. So this,
sure.
Right, this illustration is getting at, we said that we wanted to look at, adjusting or making sure we have the right rates for each plan every 3 years. And this is an illustration of, well, if we did that next year, here's kind of how the renewal by plan might shake out. So what you can see is it's not super drastic on any one plan. But I think another question that maybe some folks might have is, well, what if we just don't do any adjustments? What if we just keep everything the way it is? And, what's the danger down the road? Do you want to answer that question?
Oh.
Or do you want
That's a great question.
Oh, wasn't that a question to the board? No, just kidding. Yeah, there in this case, it really illustrates that there's not a huge danger of that. What it does say that if you let it go another couple years, 2 or 3 years, instead of having a 1% adjustment, you might have a 2 or 2.5% adjustment. So I think making these small incremental changes has some level of value. But on the flip side, if we anticipate or expected that there may be other changes coming down the road in future years, for example, waiting 1 year would not necessarily give me as an actuary any heartburn in this situation. So I do want to just finally point out, as one of the bullet points down here has, that all of these changes that we're seeing in here are just driven by the actuarial value. We're not recommending any changes to our, backroom calculations of our induced demand or incremental morbidity factors at this time.
Are these, this is illustrative, this isn't
Right.
real. So, I mean, we're not at a point where we're actually discussing whether or not we're going to do the adjustment, correct?
Correct. So what this is doing, this is using the real current actuarial values in there that we've obtained from Moda. What makes it illustrative is just that baseline 3.4%.
Got it. Okay, got it.
Yep.
Got it.
Mm-hmm. So for example, if we came in with a 5.4% increase, we'd still probably have variations from 4.4 to 6.4 would be our biggest variation. It's just our starting point would be a lot higher, heaven forbid. Did that answer your question, Tom?
I'm sorry, I'd muted myself. It does, and yet, the idea of us doing it every 3 years, we should hold to that, and making small adjustments is a good thing, as compared to having to make larger adjustments. So the idea of truing it up every 3 years is, I think, a minimum. That's just an opinion.
Yeah, it does have some good level of plan due diligence.
And I know Bill agrees with me.
I'm in love with this chart.
I
We have
you know,
one
I
more
also
hand
think we wait till it's more pronounced, then we actually cause some migration there too. So smaller sounds better to me too. Jeff.
Do you see long-term base maintaining set plans, Brad?
I think that's, certainly up for the board's discussion and decision. We've talked about decreasing plans to a high, medium, low structure. During the last, plan restructure, we did add a plan in there to address a landing point and some deductible variation that we saw. So I think there's just, as we move along, that's always, I think, open for consideration. Yeah, I think it's a trade-off between choice and choice versus simplicity and meaningful differentiation. Did that answer your question?
Just tempted to ask you, what would you do if you were in our shoes?
I think I'd talk about it.
That's now.
No, I think that, it's worth discussing. I think it really depends on what you're hearing from the stakeholder groups. And, as we move along, I think there's a couple things to think about from a design perspective. I know Jenny's going to talk a little bit about design later on, but, you want to make sure that you don't have too many plans so as to cause confusion for members when they choose. But you want to have enough differentiation to allow for folks to really buy their level of need. In addition to that, we also have the distinction between PPO and HSA plans as well that could be considered.
For the record, the stakeholder group has voiced opinions about the alignment or the relativities, and staying on their schedule gives them predictability and consistency. So I'm in favor of making a minor adjustment, along with Bill and Robert and whoever else.
So Brad, can I ask, since Kaiser isn't shown up here, that rate relativity and stability is not an issue for Kaiser?
I think we work with Kaiser as well. This is just showing the one example using the Moda plans. We did a lot of, just in particular, we did a lot of extensive work with them, 3 years ago during the plan restructure. Great questions. Any other questions before we kind of move on to the next portion of our renewal considerations? All right.
Okay, well, we may come back to this concept real quickly when we get to next steps, but first, we wanted to share with you or kind of revisit some of the benchmarking work that we presented a couple of months ago, and provide some additional insights sort of in a larger context of how to share healthcare costs with members. just as background, and Rose, you can go to the next slide, but as background, when we shared the plan design benchmarking, I think it was two or 3 months ago, the purpose of that really was to compare OEB's plans against the market, just to determine, are the plans, richer or on average the same or leaner than other plans in the market. But the way OEB is structured in terms of offering a wide variety of plans for entities to choose from is a little bit different than a unique single employer who designs 2 or 3 plan offerings for their distinct employee population, right? So we'll talk a little bit about that. But in our work with all of our, with plan sponsors of all sizes, we tend to think about and talk about member cost share in 2 different ways. One of them is the premium contribution. So how much does the employee pay for a particular medical plan out of their paycheck deductions, right? And then the second piece is point of care cost sharing. So how much does that member need to pay when they're ready for care in the form of a deductible or a copay or a coinsurance? And so it's important to keep both of those pieces in mind as we talk about cost sharing. And I know you all know this, but I just think it's good context. As I mentioned, OEB's goal is to offer a variety of plans to entities at different premium points and corresponding coverage levels so that members or entities can choose the plans that best meet their needs. And then the board tends to focus on making sure all of those plan designs are efficient and have good value in what they offer. So I think we need to talk also about the role of the entity, right? The entity will determine at some point what plan they offer and how they subsidize that plan for their eligible employees and those dependents by typically 3 ways. And sometimes they do this, with a strategy, a cost sharing strategy in mind, and other times it's determined quite a bit by collective bargaining, and then sometimes there's both, right? But essentially the entity is going to select, do we offer 1, 2, or all of OEB plans or something in the middle? They're going to determine how they share those premium costs for whatever plan they choose with those employees. And then many employers or entities also will offer some account seeding into a health savings account or sometimes a health reimbursement account, which is a separate account that members or employees can use to pay for the point of care costs, or they can save those dollars for the future. But that's also an important way of thinking about how member cost sharing plays into the whole equation. And then, as I mentioned, we review the national and industry benchmarks on cost sharing just to provide insights on how are OEB plans compared to the variety and range of plans offered in the marketplace, just to make sure that we're competitive. So we're going to review some of those benchmarks again and take a bit of a deeper dive. Any questions so far? Okay, let's go ahead and move to the next slide. There's quite a bit going on in this slide, so I'll just orient you to where we are. In the top, these are, so this slide has to do with the Moda PPO plans, so plans 1 through 5. And in the top, we're showing you our benchmark study. So of all of the plan sponsors across the US, regardless of their size, that's the database. And so what you can see off to the very upper far left, that this is the range of deductible options for PPO plans, so non-HSA plans that are offered. We just survey what plans do you offer and what's the deductible level. And so what you can see in that very far left upper box is that the database, the employers will offer PPO plans with deductibles in the range of $500 at the 25th percentile, all the way up to just over $2,000 as a deductible at the 90th percentile. So that's kind of the range. And then you can see a similar range for government public entity employers, and then a bit of a narrower range for Pacific Northwest employers, though our database is a bit more skewed towards larger self-funded employers. And Oregon and Washington and Idaho both have, or all have, a lot of small employers that tend to have higher deductibles. But anyway, the dotted lines that are going across that those benchmarks, if you will, represent each one of the deductible levels for plans 1 through 5 for the Moda plans. And we've chosen to use the PCP 360 deductible level because that's where most members are enrolled. But what you can see there is that OEB plans, the deductibles have a nice range. We're similar to the rich end of the spectrum, and we're similar to the high end of the spectrum in terms of the deductible. And then if you go over to the right-hand side, you'll see the out-of-pocket maximum level. And once again, we're benchmarking the out-of-pocket maximum level against other employers. And here, what you can see is that the OEB plans are just a little bit over or higher than the range, right? So at the low end, we're just a little bit below, above the 25th percentile, a little bit closer to the median. And then we have a few out-of-pocket maximums that are higher than the benchmark 90th percentile. So, you know, a couple of things that we can think about is, well, what can you do about that? You can certainly think about just lowering out-of-pocket maximum levels. And then, of course, what that's going to do is increase premium on the other side. So you kind of just potentially shift the equation a bit, and you might compress some of the relativities between the plans that Brad had talked about earlier, especially if you only do it for a couple of plans. So that's a few considerations. I would also say that over time, maximum out-of-pockets in the market do tend to increase. So, you know, certainly if OEB keeps the maximum out-of-pockets where they are, over time, again, the benchmarks, I think, will catch up to where OEB is. I do also want to point out just sort of a unique feature of the plans 1 through 5 on Moda. So when we're talking about these out-of-pocket maximum levels, this is on the Moda plans, they're medical maximum out-of-pocket. So what does that mean? Things like your, well, in this instance, it's your copay, your coinsurance, all apply to these maximum out-of-pocket levels. Pharmacy costs and out-of-network costs and things like the additional cost here apply to a separate maximum cost share. And that's a kind of a unique feature for Moda plans. We don't typically see something like that on other employer-sponsored plans. And so that's, you know, certainly something to keep in mind. And so that's why we've kind of listed the maximum cost share down there at the bottom. Now, the max cost share that the Moda plans have in place had originally been set at the ceilings that the federal government sets for maximum cost share for medical plans. And then we were, for a while, indexing them up to match what the federal government or CMS and HHS establishes as sort of ceilings for member cost sharing. And so, but I think we opted not to do that last year, but just so that you know, there are stop gaps in place at the federal level, and the OEB plans are a little bit below that. Okay, so that was a lot. I don't know if anyone has a question. We're going to talk about the HSA plans next because they're a little bit different.
So Jenny, can you talk about the maximum cost share just a little bit more on its purpose and whether or not it's achieving what we originally wanted to achieve?
Yeah, so yeah, that's a really good question. So if you take one of these plans here, like Plan 1, and I will just kind of caveat this because when we start talking about some of our other materials, when we do benchmarking against other plan sponsors, we back out the deductible when we talk about the out-of-pocket maximum. So when you're looking at these out-of-pocket maximums, we're showing them on an apples-to-apples basis with other employers, but in the plan documents, they're a little bit different. But anyway, if you take a look at Plan 1 for OEB, you see that the single out-of-pocket maximum is listed as $24.50, and that's at the bottom lower area of this slide. And so you're going to pay your $400 deductible if you have significant medical costs. Then you're going to pay, a coinsurance and or copays until you get up to $2,450. And then for your medical costs, if you reach that amount on Plan 1, everything is covered at 100% for your medical costs for the rest of the plan year. The things that don't apply to that medical maximum out of pocket are any pharmacy copayments, and then if you have an additional cost here for like a back surgery or something like that, then that doesn't apply. And so we probably should have the pharmacy plan designs listed here, but the pharmacy plan designs in and of themselves have their own maximum copayments for a 30 or 90-day supply, whether you're taking a generic or a preferred brand. So there's already some stop gaps on the pharmacy plan just in and of itself on the design. But there are some folks who take some very expensive pharmacy medications or have significant, out of network or other costs. And so all of those would accrue to that maximum cost share. But as you'll see, we'll show you in a couple of slides, not very many members typically hit that maximum cost share. And then you'll also see that, by design, more members end up on Plan 1, or the richer plans end up hitting their medical maximum out of pocket, and then that kind of diminishes as the plans go up. And that's because, members who do have very significant medical needs or anticipated surgeries will tend to select the richer plan designs because they cover more. So that's not unexpected. So I don't know if I answered did I answer your question?
Yes, for right now, yes.
Okay, I think we'll kind of come back to a couple of these concepts. But let's take a look at the HSA plan designs, because those are a little bit different and they have different rules. Okay, so just kind of taking a look at the deductible box at the upper left, what you can see here, so this is Plan 6 and 7 for Moda, and we also put in Kaiser Plan 3, so it's very similar. But here you can see that the deductible levels on the HSA plans are on the low end of the range that is offered out in the market. But on the out-of-pocket maximums, they're above the 90th percentile, so much higher than what we typically see in the market for a range of maximum out-of-pocket levels for HSA plans. Now, since we're talking about HSA plans, I have to point out that there, again, are these different rules. So number one, on the HSA plans, there isn't a maximum cost share like there are on plans 1 through 5. So a lot of that has to do with the way the IRS sets up HSA plan designs. So you need to have all of, and they, also for fun, set completely separate ceilings on the amount of cost sharing that a member can be expected to pay in a year than they do for non-HSA plans. So it's just, there's a little bit, they're similar, but a little bit different. But anyway, I think this is kind of interesting. And so, if you're thinking about, do we need to make some plan design changes to keep up with market? According to this study, it looks like, the out-of-pocket maximums on the HSA plans are a bit higher. Once again, though, over time, the OEB plans are going to likely, or the market is likely to catch up with OEB plans because the IRS indexes these things up every single year. Certainly, you can do something like lowering the max out of pocket for these plans, or introducing another higher deductible HSA, and we'll talk about that towards the end. These are things you can do. What we'll talk about later, and you can start to think about this, is that it makes sense to do that in a more holistic approach to the plan designs offering, rather than making these tweaks every couple of years just to keep up with market. Okay, so when we're talking about max out of pockets and whether they're in market, one of the things we need to take a look at is, well, how does that impact members, and how many people are actually seeing these numbers? And so we have that on the next slide. Okay, so this again, there's a lot going on in this slide, but this is, we're showing you the members enrolled in each one of the plans 1 through 5 and what their either individual or family out-of-pocket maximum is. And so here now we're showing you like plan 1 has a $2,850 maximum out of pocket. That includes the deductible. So now we're kind of shifting over to the way that OEB really thinks about its out of pocket maximums. So out of the 11,000 or so members that are enrolled in plan 1 and are in coordinated care, you can see that about just under 900% or 8% of those members actually met that maximum out of pocket. And then a much fewer number ended up meeting the maximum cost share of 7,900 or little over 15,000 for the family. And then what you can see here, as the plans get richer, fewer people will meet the higher maximum out of pockets. And again, kind of like what I was saying before, the folks who tend to enroll in plan 1 usually have more medical needs, and so that's one of the reasons why they're selecting that plan. But I think as we're thinking about changing, or do we need to change out-of-pocket maximums, you know, what you can kind of see below is just on plans 1 through 5 collectively, there's just 4% of members who are meeting that maximum out-of-pocket. Obviously, if you reduce all of the limits, more members will hit that maximum out-of-pocket. Yet they will also, you know, have a higher premium level for that enhancement. And then on the max cost share, less than 1% actually hit that. Okay, let's take a look at the HSA plans, because those operate a little bit differently. That's on the next slide. So HSA qualified plans have these special rules, and the way the deductibles and maximum out-of-pockets work are a little bit different. So on HSA qualified plans, a member either enrolls as an employee only, and if they do, they have an individual deductible to meet. But if that employee enrolls any dependents whatsoever, then they have to meet the family deductible before any one member in the family begins to get a co-insurance benefit. So that's very different from the way plans 1 through 5 work, where there are individual deductibles for each particular family, or each particular member who are enrolled. So here, again, you can kind of see on plans 6 and 7, you know, you do have members meeting the maximum out of pocket, but on the but it's a very small number relative to the whole population. You've got 5% of individuals who are meeting their individual maximum out of pocket, and then less than 1% of families who are meeting that maximum out of pocket. And again, that could be because if members have a lot of family members enrolled who have a lot of medical needs, they may choose a different plan that better aligns with what they need from a medical plan. And then I've listed here the different ceilings that the IRS sets every year, and for 2022, it's a little bit higher than what the Moda plan out-of-pocket maximums are. If you keep the maximum out-of-pockets unchanged, though, right, over time, that does have sort of a leveraged effect on the premium rates. So just like we talked about rate relativity, sometimes it is a good idea to adjust the plan designs every few years. And while Brad was talking about making adjustments to premium, a different way to do that is to make adjustments to the plan design. So instead of increasing a premium level on a particular plan to meet your relativity needs, you could increase the maximum out-of-pocket level to keep the plan value, the underlying plan value for that one plan at, you know, at a different level. I'm not sure how to say that correctly, but that's a different way to take a look at it. So couple of different ways to hit at relativity if we also want to address maximum out of pocket. Now, if you want to lower the maximum out of pockets, right, that's going to have a compounding effect on that rate relativity discussion that we had earlier. Questions? Okay, well, let's take a look at the next slide where we've got a few options. And again, so the question that came from the board a few months ago was, is there anything we should be doing or thinking about, or should we be reducing some of our out-of-pocket maximum levels? So, you know, we put this slide together just to help you think about how to address that question. You know, right now, OEB has 11 plan designs with varying premium levels that and coverage levels that kind of meet a variety of different needs. So if we wanted to start making changes to one or two individual plan designs, that is going to compress the difference between the premium points on those plans and the underlying value of each one of them. So we need to keep that in mind. And then, as I've mentioned several times, you know, because OEB offers so many plans, if the entities all offer all of OEB plan designs, then members do get the chance to elect a plan design with a lower out-of-pocket maximum if it meets their needs. It is just at a higher premium point. So a couple of the options that the board could consider should you want to make some changes. Well, the first one is no change. That you can just keep everything the same. It's the least amount of disruption, and over time, as I mentioned, we'll kind of get closer to market on some of the plan designs. We can reduce the out-of-pocket maximum levels to meet some benchmark ranges, and that's just going to impact premium rates and can have some member impact too, because they'll need to make some other new choices based on the new lineup. And if you lower them, you're probably going to need to adjust them every 3 years, like we're doing with the rate relativities. One thing that the board could, or that we can model for the board to consider, is to eliminate that max cost share feature on plans 1 through 5 and only have one single out-of-pocket maximum for those plans, and all the pharmacy cost sharing will accrue toward it and all others. That certainly would help simplify member communications. The premium rates would need to be adjusted, though probably not as much as if you were to simply make a bigger change to the maximum out-of-pocket level. It could diminish the impact of the additional cost tier. So the additional cost tier is, you know, that if a member is having a service that has some preference sensitivity to it, and that there's knee surgery as an example, there's an additional co-payment that a member needs to pay in it over and above their deductible and co-insurance for the actual procedure. And so, you know, if you think about if a member's going to have an expensive procedure, and you know, if they're on plan 1 or something, they're going to hit their maximum out of pocket, likely. And so, you know, if that additional cost here is accruing to the medical maximum out of pocket, there's not really any disincentive for the member, or there's no choice for the member to make. It's just actually just a cost shift. But, you know, you think about the number of members who have the additional cost here, which we will bring, you know, to the board in a couple of meetings, and the premium impact. This one is going to have a less of an impact to premium rates if you want to explore that one. And then the final option is a more a larger review of does OEB have the right plan designs, and should we kind of take a fresh look at the plans offered and do something like the high, medium, low for PPO plans and a high, medium, low for HSA plans, and it's sort of a whole redesign. And I know, Jeff, when you were asking about should we think about relativity in the face of a redesign, I might say, yeah, if you thought you really wanted to redesign all of the plans for sure next year, I might say that it would be good to also address relativity, the relativity adjustment at that time. But you know, I'm not sure if this is the year for OEB to make a huge plan design redesign. Let's go to the next slide. So thoughts on this? Okay, so thoughts on what do we do with this information that we just shared with you? You could say what we heard today was, yeah, it probably makes sense to move forward with us modeling the rate relativity adjustments along with the renewals when we bring those to you next month. I think it would be helpful to get some insight from the board as to whether or not you want us to continue to model some sort of changes to cost sharing for consideration. I know somebody asked, if you were me, what would you do? And I think if I were thinking about a larger plan redesign, I think I would recommend that the board take a step back and develop more of a point of view on the types of plans that are offered and how they benchmark against the market. Do we want to have a plan at the 25th percentile and the 90th percentile or very close? Do we want to have, what's the right number of plans? Do we want to use the WTW benchmark, or do we want to use the public entity benchmark? Those kinds of things. And we can certainly help you kind of walk through the right way to do that. But it would take a little bit of time and investment on the board's behalf to kind of go through that.
Okay, Ali, you have a question or comment? You're muted.
Sorry about that. Just a quick comment. Just as best we can, suggest that we apply an equity lens to some of the options. I think Tom may have mentioned that at a previous meeting, but I think that would be in order.
Absolutely.
All right, Jenny, anything else?
And just to clarify that, it would mean, when we looked at the percentage of people hitting the out-of-pocket maximums and the maximum cost share, it's everybody. It's not divided by race, ethnicity, language. And I understand we don't have the data complete, but it would be a start. Use what we have.
Certainly.
All right, Jenny, anything else?
No.
Okay. Thank you very much. Very detailed, and it gives us a lot to consider for next time and the time after that. All right, we are only running 8 minutes behind schedule, which is great for us. If we could take a 10-minute break, and we will come back at 3:08 and finish the meeting out. Okay, let's get this meeting back going. And Katie, I think it's now your turn to go.
Thanks, Robert.
It is. I'm
Yeah.
always on standby though, whenever needed. Hi, everyone. Again, this is Katie Schuler. I am a pharmacist and senior clinical program manager for Moda Health. Rose, if you want to go to the next slide, I'll give a quick overview of what our intent is to discuss today with the plan changes for the 2022-2023 plan year for OEBB. So first, I'm going to go through just a few pharmacy items, and then I believe I'll hand it off to Dr. Popovich to discuss some other items, the behavioral health, prediabetes, and Center of Excellence. Next slide, please, Rose. So the first I want to touch upon today, spoke about this morning in Seattle as well as in a previous board meeting last year, but our site of care program. So as a reminder to the board, we established the site of care program for OEBB in 2017. And this program sought to manage claims data that show significant variability in the infusion drug costs that are seen at hospital outpatient infusion centers when compared to home infusion or provider outpatient infusion clinics, sorry. So these specific medications are billed under the medical benefit. They are not under the pharmacy benefit, but still they're drugs, so I get to talk to you about them. So as you may recall, we implemented this in 2017, and the program really guides the infusion drugs through the established prior authorization that's already set up for these medications and steers members to the clinically appropriate but cost-effective sites of care. So it has steered for years out of the hospital outpatient into the provider office or home infusion setting. Of course, there's an exception process when applicable within that prior authorization process, and that leads to specific medical necessities, access to provider offices, or the age of the member. There's various reasons why a person might get an exception, though it's rarely asked for. We then moved into our next phase and included medications called supportive oncolytics or oncology medicines. These are treatments that help to manage side effects associated with therapeutic oncology medications. And therapeutic oncology agents targets and treats the cancer itself. So the supportive medications are utilized alongside of the drug regimen to help manage side effects of the cancer therapies. This was scoped into the existing site of care program in the beginning of 2021. And the reason we are discussing it today is because, as we promised, we continue to look for opportunities. And we know that the therapeutic oncolytic medications used to treat cancers are another opportunity to include into our established site of care program. We're actually seeing many different site of care programs throughout the nation who are moving on to include the therapeutic agents. And so this really will manage and balance the member as well as the provider experience with cost savings. These select medications would only be applicable to new starts to make sure that care is not disrupted for members who have already established a routine for their specific infusion therapy. And so through that prior authorization for a new start of medication, the selected oncology agents would then be directed to the appropriate sites of care. Now, the list would be very small to start with. And we want to make sure that the medications in scope is a single drug regimen. Some therapies include multiple oncology medications, so we're really looking to start with just one drug regimen, and that really will avoid any complexity and coordination of the multi-drug therapy combinations. We also want to select infusions that have pre-medication or pre-treatment lab requirements that a member gets when they go into the infusion center if they need to get a lab done that day, and that certainly would not be in scope for a home infusion. And we also want to make sure that the medication list has therapies, therapies that or does not have therapies that require specific resuscitation equipment to be on hand. And this again would follow the same process that's already established within the current prior authorization and for new starts only. So we're preparing to have this particular phase 2 expansion included in the renewal for 2022-2023. And again, I know we've talked about this prior, but wondered if there's any questions or points of clarification that I can help address right now. Okay. On the next slide, Rose, well, thank you. Talk about an opportunity to closely manage our glucose, continuous glucose monitors, we call them CGMs, as well as diabetic testing supplies. So I wanted to provide just a quick background. First of all, CGMs continuously track glucose levels for diabetic patients throughout the day. And they're really useful because it minimizes the number of finger pricks that a diabetic patient needs to conduct in order to make sure that their blood glucose levels are within the expected range. And so having the CGM, as you see here in the image, test that ongoing throughout the day and the night. And if glucose levels are detected that are out of range of normal, an alert is sounded to draw attention to the change, whether it be an increase in the glucose or a hypoglycemia or decrease in the glucose levels. We currently have CGMs and other testing supplies. The other testing supplies include things like lancets that are used to prick the finger when you're testing automatically, as well as testing strips that go with regular meters outside of the continuous glucose monitors. So there's kind of two different buckets here. And right now, both the CGMs and testing supplies are coverable under both the pharmacy benefit as well as the medical benefit through the DME, which is durable medical equipment. Both of these benefits have prior authorization for CGMs and preferred agents for testing strips, etc. The opportunity, though, arose because we don't have as much visibility when these agents are billed under the medical benefit. And so our recommendation is to carve the CGMs and diabetic supplies out of the medical DME space and only have them billed through the pharmacy benefit. And that really allows more visibility into specific products that members are utilizing, and that helps us identify specific costs, which is not a capability under the medical benefit, as I said. Because of this, we're unable to bill or collect rebates for specific preferred products that come through under the medical side. And again, those rebates are 100% passed through to OEBB. So for instance, diabetic testing strips, there's multiple manufacturers. We know that all of them are equally safe and efficacious. There just becomes a differential in cost. And a lot of the manufacturers have competed for many, many years on a rebate perspective. And so drug plans usually have a preferred agent or two, and OEBB has preferred testing strips. So when they go through the pharmacy benefit, we're able to see what the testing strips are billed and then send that to the manufacturer, get a rebate, and pass that fully through to OEBB. When it's billed under the medical benefit, we don't have that visibility and are unable to pass along that information from a rebate perspective. So this, and they both would have prior authorization, as I said earlier, if we carved out a medical and covered under pharmacy only, which is available today. So we've done this for other groups, and our operations team runs a utilization report to see if there's any prior authorizations established already on the medical side and make sure that we capture all of those approved prior authorizations and proactively load them under the pharmacy benefit. So there isn't much disruption to the member with having to kind of go through that process again and getting an authorized PA. It simply would be a change of venue that they're receiving their supplies, and that's something we always articulate 60 days or more in advance of any change. So this will be on the renewal, and wanted to give you a heads up or answer any questions or any comments that you have.
Does it change the cost to the member by having it move from medical to pharmacy?
Erica, I'm looking at you.
Yes, I see you looking at me, Katie. Yes, it can impact the cost to the member because the benefits are different. Generally, the cost to the member would be lower under the pharmacy benefit, but there could be a chance that it could be higher if the member had reached their out-of-pocket maximum. But under the medical benefit, usually it would be a 20% co-insurance that's subject to the deductible compared to the co-payments or caps under the pharmacy benefit.
You took my words just right out of my mouth, Erica. Thank you.
Well, great.
Does that help answer questions? Or do you have any other follow-up questions? Okay, thumbs up. Great. Okay, so moving right along on our next and last pharmacy slide, I wanted to make mention of something oh, Susan, yes, please.
Hi, Katie.
Hi.
I was just wondering if it were under the pharmacy, would the person be able to do their own, what you call it, the rebates?
So good question. So most of these claims are going under the pharmacy benefit already. It's just some that are going through this DME supplies. And the member experiences the rebate through premiums. And so this is kind of that contextual, taking advantage of rebates to obtain the lowest net cost. So there's less cost to OEB, and those rebates are passed through to OEB, but we don't have member-specific rebates. Erica, I feel like you want to add something.
No, I was just, if you had questions, I would add, but nope, keep going, Katie, if you've got it.
Okay. And, you know, again, I just want to make clear for some people who may not have heard my spiel 10,000 times, but we are very driven by clinical evidence. And so where something makes sense from a safety and efficacy perspective, we're going to prefer those agents. It's just if there's a tertiary factor of cost that might make one lower cost and more beneficial than the other is when we really entertain rebates. And as I said, for the testing strips, the whole nation signs up with rebate packages. And so I don't know if I probably described kind of how that whole process works in 2 minutes. But the preferred test strips do come at a preferred cost to a member. And so.
Yeah, and Susan, I think to specifically answer that as well, we are not able to administer where the member would get the rebate at point of sale, if that was the specific question.
Yeah, if they would be able to access that themselves. Is there, on a different question on the same topic, what is it significant, the amount of rebate that comes back to OEB?
Yeah, so it's very dependent on what particular product is utilized, but in the testing space, those rebates are pretty significant, and whatever is collected from the utilization for OEB is 100% passed through to OEB. So I would say it is very significant.
Thank you.
Jeff, did you have a question?
Yeah, I just want to reiterate that if we were able to negotiate passing the rebates on each individual, that there would be an increase in administration cost, and re-emphasize the fact that Moda does not keep any of the rebates. It all goes back to OEB and reflected in reduced premium.
That is correct. Thank you, Jeff.
And I can share those numbers with you, Susan, if you're interested in them.
I so appreciate the team approach in helping to answer that question. Thank you, everyone who jumped in. Okay, so we're going to dig a little more into the emerging cellular and gene therapies. I'm sorry, it's a new year and I'm like getting back on track, it seems. So I wanted to provide this particular topic. We already have laid the foundation to tackle the opportunity in this particular space, but I wanted to note this here because part of our point of the presentation is to remind the board how we are working to manage cost into that 3.4% or actually below if we can. And so quick background, there's very complex and new medication therapies that are available, and these are gene therapies. Gene therapies work to manipulate particular genes within a person's body, and it manipulates the expression of the gene, or it alters the biological properties of the living cells to treat or cure a rare disease. And so this isn't something that OEB is going to have a lot of members being in line for these particular treatments and medications, but this is very important because if a person does have a rare disease, we want to make sure our program's in place so we can help get them the best care and the best outcomes, and then downstream have the best, cost outcomes as well. And I really love this image here. This is the DNA, and it's showing, being able to snip out of the DNA. And this really is what these drugs do. An example of this therapy is called Zolgensma. I'm so sorry. This is a provider administered medication, as many gene therapies are, billed under the medical benefit. This specific one is used to manage a rare spinal muscular atrophy disorder. It's a degenerative genetic disorder. Not many people have it, but we have a therapy that came out, gene therapy. It's approximately $2.125 million for a one-time infusion. The clinical trial was only conducted in 20 people because it is so rare. So that's just one type of example of a price tag. Moda wanted to really pursue and establish centers of excellence models that steer participants or recipients of gene therapies to hospitals that have the expertise to manage these complex therapies, many of which actually participated in the clinical trials themselves. So as you can imagine, with these therapies or conditions being so rare, there aren't many experiences in all the hospitals throughout Oregon, for example, who really know how to utilize this new novel treatment and kind of have the best outcome. And so we want to just ensure that we allow for treatments to occur within an optimal setting and practical experience, so high quality of care is delivered in treating these patients with rare diseases. We are beginning to construct and implement this strategy for fully insured groups, and it will provide a safety net should OEB have a member with such a rare disease. So for instance, this would be Luxturna is another example. That's a gene therapy for a really rare pediatric eye condition. And there's a few hospitals in the nation that have the expertise to really deliver the medication. And so being able to set up models for which if a member came onto the OEB plan and was in need of this medication, we can help set them up with a hospital that has the most experience in treating these pediatric patients and have the best outcomes. So just wanted to kind of remind here, it's not a high volume one, but should we get one person, it would have a huge impact in outcomes and costs.
Hey, Katie, it would be great if you could wrap this segment up at by 3:30, 3:32, something like that.
I'm going to do better, and I'm going to pass it on right now to Dr. Popovich. I so appreciate your time management. It's so needed. Thank you. So if there are no more questions, we can move on to the behavioral health, and thanks for listening.
Okay.
Thank you very much.
Yeah, thank you, Katie. Good afternoon again. Today I'm going to talk to you about a few of the initiatives we're looking to implement for 2023. I know we don't have a lot of time, so these will be brief overviews and hopefully not too repetitive from this morning's CL session. The first is our coordinated care model for behavioral health. Many of you likely already heard the details of the plan this morning when Dan Thoma, our Senior Manager for Behavioral Health, presented this exciting program. Our goal here at Moda is to address the behavioral health crisis that this state and really the entire country is facing with the pandemic. This program would address the fragmentation that we currently see in the behavioral health provider world and incorporate value-based payments and contracts that carry with them ways to be working with our provider network better, increasing accountability and outcomes. It will integrate deeply into Moda 360, giving members significantly more options with point solutions, for example, and assistance in obtaining the care they need for their specific issues. As Dan put it so well this morning, it will turn the experience of seeking care on its head, allowing for easy access to a provider, accurate matching to the right provider, and confirmed treatment outcomes. Next slide. The next initiative is our diabetes prevention program. This is a program we're going to be calling Pre-D, and this is an important niche to fill with OEB, knowing that the current vendor is leaving this space. So just to give a little background on this problem, nationally, 1 in 3 adults, 88 million, are pre-diabetic, with many not realizing that they are even at risk. In fact, over 84% don't know that they have it, and that's per the CDC. These people are at very high risk for type 2 diabetes, heart disease, and stroke. By adhering to a CDC diabetes prevention lifestyle change program, the risk of a member progressing to type 2 diabetes is cut in half, 58% actually, and even higher for people over 60 to 71%. It also reduces the serious conditions associated with prediabetes. Historically, engagement and retention in pre-diabetes programs has been poor, and rates are even lower for Hispanics and other underserved ethnic groups. The core components of these programs are weight loss, which is charted and documented via diet and lifestyle modifications, introducing physical activity into members' lives, support groups, stress management, and ways to adhere to the program. Next slide. Third-party vendors have been tried and have been somewhat effective in engaging members, but in retaining members is where they have fallen short. And having those members make it through the program over the long term has been problematic. We know that identifying members with prediabetes early and engaging those members effectively can lead to significantly better health outcomes. Certain social determinants of health can lead to higher chances of developing diabetes. Therefore, enhanced targeted efforts at these populations will be an essential part of the program. We proposed the Pre-D program, an internally built diabetes prevention program modeled on CDC guidelines, as an initiative to address these member needs. It will incentivize members to complete pre-diabetes screenings through our new member portal and Moda 360. It will implement a CDC pre-diabetes defined program with weight loss, lifestyle modifications, and coaching. It will incorporate one-on-one sessions with Moda lifestyle coaches to assist with individual goal setting, accountability, and program retention. It will also provide incentive through the plan designed to encourage engagement with the program and coordination with PCP 360, as provider outreach will be very important for the success of this program. Next slide. So, quick segue now into Centers of Excellence, a topic I know you've all heard about. This first slide here is a good summary of the framework that we have followed at Moda to bring the musculoskeletal program together. It essentially demonstrates the 3 phases of a member's journey to musculoskeletal care, and that is prevention, steerage decision support, and then surgery support. Next slide. So prevention, what I'll say about that is we don't think anyone would argue with the fact that we'd rather a member not have to go through this process, that their joints and spines remained healthy. But to that end, we strongly believe in prevention, as illustrated by our Wellness Advisor program, as well as our Moda 360 Health Navigators. They will guide the members to the wellness programs that make the most sense for them. Our implementation this year of the SWORD virtual MSK program should and will go a long way in helping guide patients along to prevention and a non-surgical pathway to resolution of their symptoms. And along those lines, the SWORD program will also carry over into steerage and decision support, because not only is it about prevention, but it's about physical therapy, and it's about getting patients as far along as possible without having them to get to surgery, and should they need to go to surgery, taking care of their needs after surgery with physical therapy. Which then brings us to the last portion of this, which is surgery. Should members need surgery, our prime directive and goal in the implementation of this program has been quality and access for all of our OEB members. We've been in the process of building this network over the past several months, and we'll keep the board apprised as it continues to take shape. So that is 1532. I think that's what you were looking for, right? Any questions on any of those programs? I know it was very quick, but hopefully it gave you a taste.
I apologize for rushing you through it, but you did
That's
it very
okay.
well.
No
So,
problem.
Thanks.
No problem.
Okay, it is Kaiser's turn. Dr. Bachman for Sapari or Jennifer?
Great. We're going to have Jennifer Stacy start us off here. We're happy to be here, and we're going to be talking about how we're planning to deliver quality care at the same time of managing affordability. Jennifer, to you.
Yeah, thank you, Dr. Bachman. Happy New Year, and thanks everyone for having us. As we prepare to talk about our current work and our future efforts, I think it's helpful to ground ourselves in where we are now and how we've gotten here. So, as everyone knows, the past 22 months have significantly impacted our state and really our nation's clinical systems, strained our public health organizations, as you are well aware, and pushed many of the support systems to the brink. COVID-19 has and will continue to drive costs into healthcare, including the obvious things like providing care, vaccination, and testing, but also safety needs and stress on staffing. So, as Bob and Brad both mentioned, the Great Resignation has begun, and it is impacting healthcare providers just like it is some of the other significantly strained types of jobs, and will not understand likely what that outcome will look like for a while. But one area that might be an early indicator is the contracted workers that many health systems use. So with the increased demand and decreased supply, for instance, of nurses, the rates for those workers have dramatically increased. And I don't expect that to go down as long as the demand continues and we see people opt out of the workforce. Other inputs, of course, include patients with higher acuity health issues, a dramatic increase in the need for behavioral health and substance use disorder treatment, and then many just deferred care problems that we're seeing. At the same time, we're seeing a societal reckoning that demands that we really improve the equity, diversity, and inclusion of our workforces and the way we treat people, and that we support those who are most vulnerable. So with all of that doom and gloom, I think the great news is that we know that Kaiser Permanente is well positioned to meet these challenges. And we, like OEB and the OHA, are focused on the right work to really drive towards quality, affordability, service, and equity. So Sapari and Dr. Bachman will discuss a few of the specific efforts and programs that we'll be working on. But for 2022, an overview is that we'll really be doubling down on our work to connect members to care with a strong focus on primary care, behavioral health, and chronic condition management. We'll also continue to focus our efforts not only to build a diverse workforce now, but to improve the diversity of care providers in the future. So getting really young and helping support people who can work into the healthcare system. And then finally, we'll continue to address those social drivers of health. As Yale noted, this is incredibly important, and it's work we've already begun. So we'll not only continue to screen their members and connect them to the social supports they need through Thrive Local, the Unitas platform, but we're going to be evolving our care from chronic condition management to really social care management, as we know that addressing the key issues outside of the exam room are absolutely critical to being able to help a member achieve their overall health. So thanks again for having us, and I'll turn it on to Sapari and Dr. Bachman to move us forward.
Great. On to the next slide. So this slide sort of indicates the main buckets that we're going to be talking about today in the next 15 minutes. And these are all places where, with our integrated delivery system, with our priorities that we have, with the goals of the Oregon Health Authority that we're in alignment with, we think these are things that can demonstrate both ways of improving quality while ways of mitigating cost. Those things include, as Jennifer mentioned, increasing primary care services, which we're already strong in. We're going to double down on that and recognize that when we have strong primary care integrated with behavioral health care, that and assessing for social needs and managing those social needs, that will ultimately be the most effective strategy to provide value-based care and catch illnesses and diseases at their earliest time. Below that, we talk about inpatient and outpatient care, and that's really making sure that we are using inpatient services appropriately. So that's a variety of techniques, strategies, and tools that we have to make sure that every day, really minimize the number of days our members stay in the hospital, which ultimately results in better care and affordability. Below that is pharmacy management. And this really looks like what we've talked about many times before at OEB about the way our pharmacy program is designed. The integration of pharmacy care and medical care really allows us to do some very special things in terms of purchasing and in terms of really choosing what drugs to use at what time. Sapari will be taking us a few ways that we're streamlining our administration, which will help manage costs. And then finally, we'll end with a few of the new initiatives that we're excited about. Next slide, please. So I mentioned primary care, and again, we already have a strong medically home-based primary care delivery system. The goal in 2022 and beyond is really to strengthen that, improve access to primary care, include behavioral health in primary care, use the primary care team in helping identifying social needs, connecting members with social needs up to resources and long-term follow-up. As was mentioned this morning at CL, it's found that when care is done at the local clinics and primary care, it's more likely to be culturally responsive, given that primary care environments are community-based environments. That doesn't mean there's plenty of stuff going on virtually with physicians that can be deployed from anywhere, but when a member knows who their team is, where they're located, how to access that care, we find that it is most efficient and does the best in terms of improving quality and decreasing low-value care. So again, one of the important levers for 2022 and beyond is making sure that we are maximizing the benefits and focusing our members in primary care and that primary care, that PCP member relationship. Next slide. Next slide after that. So keeping people at home, we talk about hospital days, but even more important, the converse of hospital days is home days. So what are the ways that we can keep our members at home? So two programs to talk about. These are of several more, but two of the ones we're most excited about. One is KP at Home, and this is really our hospital at home program. These are well-established programs that have been used in other settings for the last 15 to 20 years. They're improving as the technology improves, and they result in about a 20 to 30% reduced cost per day. So these are members, patients that have illnesses that really need to be, that usually traditionally are treated in the hospital setting, but with adequate support, with the right technology, with an organized system of care, we can manage those conditions at the home setting. Certainly this was useful in COVID. The care for COVID is primarily supportive with high flow oxygen, with monitoring, with some intravenous medications. All that can be delivered at home. So it's not just home health. This is actually physicians rounding on a daily basis. This is IV services. This is home health aides. This is supporting the family. This is keeping people at home. The patients are delighted with this program. Not everybody can participate. If you don't have support at home, this won't work. But for people that do have support at home, this is a great program. If someone doesn't have adequate Wi-Fi, we will bring the Wi-Fi into them and have technology that can provide that linkage so the patient and their family can connect with a nurse 24 hours a day, just like a call button in a hospital. Successful program for a variety of cases that would typically be managed in the hospital, can be discharged from the emergency room into this program. It's expanding from the Portland metro area, and this year we'll go to Salem as well as into Southwest Washington. Outcomes have been positive, low rates of readmission, high patient satisfaction, high family satisfaction with care. Second part of this is surgical home recovery, and this is really keeping patients not overnight in the hospital after surgery by careful planning, by careful education, by proactively developing a recovery plan. We are finding that a larger and larger percent of cases that typically would have been kept at home, kept in the hospital for one night or two nights, surgery can be performed during the day, and they can be sent home that evening. But 80% of our hip replacements and knee replacements are being done with home recovery and we're moving to a higher percent of other kind of outpatient surgical procedures, such as gynecologic surgery, and some general surgery procedures as well. That is, this reduces hospital days, actually increases safety, and we are ramping up the numbers and the kinds of cases that we can do with the surgical home recovery. Again, lower days in the hospital, lower costs. Between these two programs, there's at least 30 people a day who otherwise would be in the hospital, and that's a whole nursing unit that we are saving. The nurses are still being deployed, but it's much less expensive to deploy that care at home than all the overhead in a hospital setting. Next slide, please. This talks about care management, and really same philosophy here. These are high-risk patients. How do we keep them from, they're going to need a lot of care, but how do we do that care at the most efficient way, and how do we impact them at the earliest stages? On the left side of the slide is our UPenn Impact Pilot. This is a model that came out of the University of Pennsylvania that looks at our members at highest risk, which includes social needs, uses peer community health workers in certain situations, and really using this as a key way to manage people with high risk conditions. Again, it's the social needs that tends to drive much of the utilization. If we can impact on the social needs, if we can do great disease education at home, we can be successful. We've fully evaluated this. We've tested this with additional pilots, and we saw reduction of hospital stays, cost avoidance, increased social screening, increased social needs met, and decreased ER utilization. And then transitions in care, people that have been in the hospital, avoiding readmissions is something that's obviously a target area as well. So we are upgrading and revamping our transitions in care program and developing a virtual transition clinic. So the hospitalist that takes care of somebody in the hospital then does within a couple days, video follow-up visit, provides that continuity, makes sure all the details are taken care of, and a great transition back to primary care. Pharmacy management is integrated into this as well. Next slide, please. Another way of lowering waste is reducing costs and reducing variation. So it's actually millions of dollars a year can be saved, and we're actually started this last year. We're going to continue it this year in decreasing, in really thinking about the surgical supplies that we need. Surgical supplies can be very expensive. Surgeons come in and kind of with what they've been trained in or what they're used to using, but as an organized system of care, we can have our surgeons and our surgical teams kind of come up with a standard set for each surgery, and there's actually huge cost savings. So once in a while, there's a little bit of additional training that needs to happen, but typically just everybody's fine with standardizing the tools that are needed for a certain surgery, which ultimately has a marked reduction in cost. There's huge variations in the costs of various kinds of sutures and staples and the supplies needed for laparoscopic surgery. And then finally, reducing inappropriate imaging is another place where there's a great deal of waste. Lots of physician preference about when to use MRIs versus other kinds of less expensive modalities. And we know there is a lot of waste in MRI utilization, MRIs that don't actually need to get done because the patient didn't need surgery or actually didn't need the data from that. And so we're being a little bit more cautious on how we use MRIs. It's more than just a pre-authorization program because it's really peer-to-peer review and discussion about what the best, for an individual basis, what the best imaging modality would be. We've been doing backs for a while. We've been doing brains for a while. We're moving to ankle MRI and shoulder MRI through this program, which has been successful at not just reducing MRIs, but reducing MRIs that don't add value. Next slide, please. The next pharmacy, this is really similar to what we've presented before. We save around $20 to $25 million a year with our specific key pharmacy initiatives. One of those is strong deployment of our mail order pharmacy. We know that improves adherence to medications, which reduces some downstream costs and lowers the cost per fill of a medication. As a very large pharmacy program, We can employ strategic national purchasing for both generic drugs as well as specialty expensive medication. With an organized system of care, we can have very high use of both generic drug and preferred drugs, and we can do certain things with dose consolidation, deploying pharmacists in our within our program, both for chronic conditions like diabetes and hypertension, as well as for specialty care such as Hep C, HIV, rheumatology that have the expensive medications. Again, the medical group working with the pharmacy group really leads to great care, high quality, and cost savings. Next slide, please.
Perfect.
With that, I will turn it to Sapari.
Thank you. Thanks, Dr. Bachman. So in addition to our care delivery services, we are also continually looking at the administrative cost controls. So we've implemented various systems and audit functions to help ensure that claims payments are accurate and that charges from our vendors where members are seen in external settings such as the emergency departments and in and outpatient services are accurately captured and reimbursed. So we're projecting about $6 to $7 million in savings in 2022 for the payment integrity program. We've also internalized or have internalizations planned for 2022 to bring services into KP by leveraging our internal resources and assets. A few examples of this includes bringing in-house molecular genetic lab testing, peritoneal dialysis, and we're opening up 2 new operating rooms at our Sunnybrook facilities. And these efforts are targeted to save approximately $3 million for this upcoming or for this year. Next slide, Rose. Thank you. Under contracting, there's great advantages of being part of an organization that provides coverage for over 12.5 million members. We can leverage our national purchasing power to negotiate favorable rates for program-wide contracts and are targeted to save approximately $13 million in this coming year in contracting efforts. As for discretionary spending, there definitely have been a lot of downsides to the COVID pandemic, but on the upside, it has forced us to rethink how we do business. Although there's value in meeting and seeing and learning in person, we've also been able to cut our spending by moving to a virtual environment. And as we know, I mean, it's not perfect. We are learning to flex, and we are planning to sustain these savings into 2022. And lastly, next slide, Rose. And one more. Perfect. Lastly, I just wanted to call out a few new or newer initiatives that we launched to support access and care to our members. Get Care Now, our on-demand video and phone visits with a clinician. This is our virtual, I would say our virtual urgent care services, which provides 24 access to our Kaiser Permanente visit or clinicians. Chat with a clinician really is an extension of our e-visits. So extension meaning that as you go through the algorithm for our e-visits, if there are symptoms that are kind of outside of that algorithm, the member has the ability to chat with our clinician to ask questions and to talk about or discuss how to receive care. Increased digital engagement was launched to support patients before, during, and after appointments. So for example, we send appointment reminders 48 hours in advance, reminding members, that their appointments are coming up. And then while they're in their clinics, we're also sending them messages about care gaps that they could take care of while they are there. And then post-appointment task nudges, such as, picking up their prescriptions after their appointments, are also translated. And then under outpatient pharmacy language translation, we now offer prescription label and drug information sheets in 14 additional languages, and that's not including English. So some of the other language includes Farsi, Korean, Romanian, Russian, and of course Spanish. And then lastly, for our late sequela, I always have to stop to pronounce that, our late sequela clinic, we launched this new clinic to support members experiencing prolonged symptoms of COVID. According to the CDC, about 10 to 30% of COVID patients will experience prolonged symptoms, which can vary from person to person and range in severity. The clinic's medical team reviewed hundreds of COVID cases to identify patterns and symptoms, and based on their early learnings, they developed a panel order to help support our providers to evaluate symptoms and provide treatment. And we can continue to keep you posted on progress of all of these initiatives, but that is all we have for you. So I'm going to turn it over to Jennifer to see if you have any closing comments.
Thank you, Sapari. Really just wanted to thank you again for continuing to partner with us and allowing us to provide care to your members. I hope this gives you just a sampling of the many things that are going on, and we can bring back detail on any of them. But thank you, and we'll turn it back.
Thank you so much for the presentation. We are moving on to Jenny and Brad for hospital cap audit results.
Brad, I think you're on mute.
All right. Well, that's better, isn't it? All right. So as I was saying on mute, we thought it would be a good idea to give a summary of the full audit report that we presented to the IWG in late December for the Medicare 200% reimbursement cap audit that we've been performing over the last few months. As a quick reminder, recall that SB 1067 was effective for OEB in October of 2019 and for PEB in January 1 of 2020. And it limits facility reimbursements to 200% of Medicare for in-network hospitals and 185% for out-of-network hospitals. And while it applies at a claim level, compliance is determined at a hospital level for the regulations. So kind of in short, as part of our executive summary, all of the carriers separately meet the criteria for SB 1067. And in general, all of the reimbursements at a hospital level are in compliance, although a few of the hospitals did show some modest level of overpayment. When we look at the results on an individual claim level, we did see some opportunity for further review with carriers to reconcile what we saw as some potential overpayments in there. So as a supplement to this audit analysis, we also were asked to perform a savings analysis of 1067 and sort of see how it compared to our initial estimates of 81 million or 23% of facility claims that were subject to 1067. So as we, kind of performed the savings analysis in general, we saw savings of 59 million, which equated to about 14% of our facility claims. And that was lower than expected. And we really identified three primary drivers of that variance. The first being delayed implementation of the clarified rules. Preliminary 2021 data does show or indicate a lower average reimbursement when we compare to 2020. So we're anticipating some effectiveness there. And then also the change in utilization patterns due to COVID-19 drove lower utilization, lower claims there. And then frankly, we think maybe those estimated savings may have been a little too high. What our actual pre-1067 percentage of Medicare were a little bit lower than had been indicated in that initial savings analysis. Any questions on the executive summary before we kind of dive into some of the results? Okay, so we can move to slide 5. And we thought it would be as a first step kind of to take a look at and see what amount of these facility claims were actually impacted by 1067. So we can look at this, first on a combined basis. We see that of the, 200 plus hospitals that submitted claims, that we had about $620 million of charges. Of that, we had about 13% of those outside of Oregon. Of the remaining claims within Oregon, we had about 22% of the total were in Oregon, but at exempt hospitals. And that left about 65% of our claims, or a little over 400 million, that were incurred and impacted at subject facilities. So in general, these results that we saw were similar for OEB and PEB. If you go down there and look at them, we have OEB at 64% and PEB at 65% of claims. With Moda and Providence also having similar percentages, 61 and 62%, and Kaiser with a larger percentage of the total claims subject to 1067. So, all in all, looking like we hit about 2/3 of our claims were impacted by this legislation. Any questions on that before we dive into the results? Okay, we can move to slide 6. And you'll note first a little bit of a difference. We were not able to completely map all of the claims and re-adjudicate them from a savings perspective, but we hit a lot of them. So you'll see that 392 is a little bit lower than the 403, but very representative of that total group of claims. Overall, OEB and PEB reimbursed claims at 179% of Medicare, which is below the 200% cap or target. And when we aggregate results at a hospital level, only a few facilities had modest overpayments that totaled about $700,000 or 0.2% of claims. So very, very favorable results there. When we look at results on an individual claim or a per admission claim level, both OEB and PEB had approximately 2% of claims that were paid or appear to be paid over the 200% cap. There don't really appear to be any differences between OEB and PEB for either inpatient, outpatient, or when we look at it on a per hospital or per admission level. So very similar results for both groups. Any questions on that? All right. So in general, favorable results, seeing in general, seeing very good compliance in there, and in general, seeing great compliance in there, and a little bit of opportunity for further discussions with the carriers on some of those what appear to be overpayments at an admission level. So, but very good results so far. Any other questions on that, or any questions on those results?
I don't see any, Brad.
All right, man, it was a lot of work. Deserves at least a couple of questions. Maybe one. I'm just kidding. Okay, so we can move on to slide 8, and we'll look at the savings analysis now. So that first piece was on compliance, and passed very well from a compliance perspective. Moving on to the savings, you'll note that we're looking at a 2-period or a multi-year period. Because we really felt it was good to see what savings could have looked like in a non-COVID year as compared to what savings looked like in the last year, which were pretty impacted by COVID there. So as we look at these, it can get a little bit confusing. So there's 2 key things to remember. Our percentage of Medicare before SB 1067 is based on 2019 contracted rates in general, and our percentage of Medicare after SB 1067 is based on our 2020 contracted rates. And so you'll note in the 2019 section, we have a percentage of Medicare, kind of before 1067, and we also have a percentage of Medicare after 1067. And you might ask, well, how can that be? It wasn't implemented. Well, we've said, hey, what if the adjudication from 2020 applied to the 2019 utilization? How would that have looked? So we're kind of doing a what if look, but based on the case mix and utilization mix of 2019. So in general, when we look at inpatient, on a pre-1067 basis, we came out with a percentage of Medicare of 182%, which is actually less than the 200% target in there. So this is lower than the initial estimates were, and it did result, I think, in limiting some of the savings opportunity in there. However, when we go back and we look at the 2019 section, we can see savings would have, as adjudicated, would have been relatively flat. However, if we kind of look at the column titled Estimated Savings If Capped, that's a really kind of a long way to say, well, what if the clarified rules had been implemented? What if we had capped those at the lesser of allowed contracted or billed charges or the 200% of Medicare. And we would have seen some pretty significant savings there, almost 27 million. So that's kind of one reason that we think that, wow, those clarified rules are going to have some level of impact in there. For 2020, utilization mix did drive negative savings compared to the pre-SB 1067 percentage of Medicare. So we actually saw an increase in there, so a negative savings of 4.5 million. However, when we go back and say, well, what if those had been, capped, sort of under the clarified rules, we actually would have seen savings of over 13 million. So, again, there's definitely opportunity under those clarified rules for inpatient. So when we moved to outpatient, our pre-1067 percentage of Medicare was 240% to 250%, right around in there. And that's close to, but lower than our preliminary estimates, so consistent with inpatient there. However, in 2020, we did see earned savings of about $64 million, which exceeded our expectation given our 2020 case mix. So very good results for outpatient in there. If we kind of want to zero in or look at inpatient on a carrier basis, for Moda, we did see the percentage of Medicare increase from about 170 to 188%, and that drove a cost increase of about 7 million. Providence percentage of Medicare decreased from about 199 to 187% for a savings of about a little under 5 million. And Kaiser percentage of Medicare increased from 146 to 154 for a modest cost increase of 2 million. And kind of netting all that in total, as we mentioned in our executive summary, we did see savings of about 59 million, and that was about 14% of our impacted claims. Again, a negative or cost increase of 4.5 million offset for inpatient, offset by outpatient savings of just about 64 million. And I see we've got a hand.
Yeah, this is Tom. What happened in 2019, I think, also was that Moda dropped the Summit Synergy, and that may explain why costs actually went up for inpatient for Moda. Is that a correct analysis?
I would have to defer to Moda on their contracting, but I do understand that there was some level of unit cost give up on that.
Okay.
I'm not sure it was that substantial, but
okay.
But I do know there was some level of that. Good comment and good question. Any other comments or questions? All right. So we can move to slide 9. In the IWG, we have been talking about a little bit of the primary cost drivers of that increase on the inpatient side. We did do some deep dive analysis down by DRG code and have a few highlights here. We've chosen the top 6 DRGs that drove cost increases and the top 6 DRGs that drove cost savings in here. And so you can see, a couple of interesting observations in here. Our cost increases are generally driven by a few key DRGs, while cost decreases or savings were really spread more evenly across the DRGs. So cost increases were concentrated, almost 50% of them, I believe, were driven by neonate codes between 789 and 794. So we had some pretty substantial increases in those codes. Kind of looking at those, you can see that the percentage of Medicare before for some of these codes was around ranged anywhere from 50% of Medicare up to 130% of Medicare. And of course, after 1067, we were much higher at around 140 up to almost 180% of Medicare. And again, these were under the non-clarified rules. So those together drove a fair bit of cost increase. In particular, diagnosis 790, the DRG 794 has pretty high utilization in there. We did add utilization columns into the chart, so you can see for 2019 to 2020, and in fact, utilization for that code did go down period over period, with 557 in 2019 and 549 in 2020. But that one code did drive, a $6 million of cost increase. And we're hoping to see that change. And we have seen some early indication of that change based on very preliminary 2021 data. Any questions on that or comments or thoughts? I'll also note that we did not produce a similar chart for outpatient. Outpatient is a much more complicated, episode type pricing process. And frankly, we did not see this kind of cost increase associated with the outpatient side as we saw on the inpatient side. So we do have some outpatient data in the full report. If you're interested, we'll be happy to forward a copy of that to you. All right, so we can move to slide 10. In addition to just looking at savings analysis and doing some year-over-year comparisons, we also did some comparisons against commercial benchmark. In this case, our commercial benchmark was using the 2019 IBM Watson market scan data. Interestingly, pre-1067, both OEB and PEB inpatient costs were below benchmark. Kind of if we look at the center lower column in there, we start with OEB, PEB, and then do a combined, where we have inpatient as the first line started at 176%, ended at 180%, and that's compared to market of about 200%. So both starting and ending similar, both below benchmark. On the outpatient side, the pre-1067 were above benchmark at 243%, and that compared to our kind of our commercial benchmark of 196%. And after 1067, we ended up at 177%, which is below benchmark. So, on the inpatient side, not too much movement, a little bit of an increase, but still below benchmarks. On the outpatient side, a substantial shift in change, moving from quite a bit above our commercial benchmark to a fair bit below our commercial benchmark. So very successful in both of those ranges. On a combined basis, we're at about approximately 180%, which is lower than the benchmark that's near 200%. So very, very favorable results when we compare the change to the commercial market out there, and that is for the Oregon region here. Any questions on that? All right, we can move to slide 12. And kind of as a little summary and next step. So, in general, again, most hospitals, almost all hospitals meeting the criteria. We do have a couple that had very modest overpayments. At admission level, there does appear to be some level of overpayments, and we are prepared to start a reconciliation process on those with the carriers. And from a savings perspective, total savings were less than expected, but this was driven by inpatient, which we think should be helped, by the implementation of those clarified rules. And hopefully, once we see those clarified rules and see the impact, I'm hoping that we will be back up to, somewhere close to our initial expectations that were presented back in 2018. So from a next steps perspective, again, that work with the carriers to resolve these overpayment issues. I think we also need to determine the frequency of our future audits, and we're recommending at this point from an audit perspective, every 3 years. Of course, that needs to be reviewed, make sure that satisfies regulatory requirements. And then we do recommend conducting an additional savings analysis once the 2021 data is fully available to gauge the impact of those clarified rules. And we have lots of great stuff in the appendix. If you're interested, you can take a deep dive in there. But other than that, we'll take any questions or are ready to wrap up.
Any questions? Okay. Well, thank you, Brad. I really appreciate it. All right.
Absolutely.
We're going to move on to which one goes first? Is it IWG or is it CL? Let me go back up. CL.
Okay. So we had 4 topics that we went through today. We had the plans talk about changes that they're looking for 22-23. We just heard at the board meeting Modas that included the behavioral health work. We've heard about site of care, the diabetes prevention program, and I'm blanking on the other, but we agreed in principle with all of the recommendations. We still need to see what the costs for these, the cost implications of these changes, and Moda wasn't ready to present that, but we thought, again, it was appropriate. Kaiser is looking at changing their alternative care for, in fact, their entire commercial book of business. And this relates to needs to meet essential health benefits requirements. That's part of Oregon's simplified benefits plan, something I was not familiar with. So this is alternative care, meaning acupuncture, chiropractic, and naturopathy. Currently, the plan is basically, this is self-referred, and there's a $2,000 maximum combined allowance, and it's managed by a company called CHP, or Complementary Health Plans. There also is a physician referral benefit that is outside of the $2,000 allowance. That would be if someone, let's say, sees their primary care doctor for a back strain and wants to see chiropractic. If it falls within criteria, the physician could make that referral, and that referral would be outside of the $2,000 maximum. They are proposing moving to a claim, a visit-based benefit for acupuncture, 12 per year, 20 for chiropractic. Naturopathy moves outside of this supplemental benefit and moves into a core benefit. I in particular had questions about that because it sounded like the self-referral to naturopathy would be outside of their integrated delivery system, and we'll follow what happens with that. Looking at their current utilization, this actually resulted, these changes, in a very slight decrease in the cost per member per month expense. So we agreed that, you know, a regulatory change that is requiring them to make a change, we agreed that that was an appropriate change, and that will all move forward into the rate making process. The third topic we dealt with was member benefit requests that have come in during the past year. And there were 2 specific requests. The first one was for coverage of breast reduction surgery. Now, what was odd about this is that both Moda and Kaiser Permanente have coverage for breast reduction surgery within certain medical criteria that are pretty much industry wide. So we were, again, a little surprised by the request, and we asked OEBB staff to go back and to see whether or not we were missing something. But as a group, we were in favor of continuing our current coverage as defined through medical necessity criteria. The other issue had to do with out of area, whether or not we need to change and improve the plan offerings for people who are currently living outside of the area. Now, out of area coverage for Kaiser Permanente, for Kaiser Permanente Northwest, it's from Longview to Eugene and basically the Willamette Valley. That is their service area. For Moda, it's all Oregon counties plus areas of Southwest Washington and Western Idaho. That is their service area. We had the numbers of people. Willis Towers Watson brought the numbers. About 360 people, members, including dependents, are living outside of the areas I just defined. Interestingly, 2/3 of them, 240, are retirees. About another 30 are COBRA, and only 90 are actual active employees and their spouses / dependents. So with that in mind, I mean, what they get, what the members get, particularly who have Moda who live outside the area. Moda has a nationwide network in all 50 states that's basically based on the PPO benefit level coverage. It does not include any of the care management benefits that are there. So we recommended not to ask Moda to make any changes in their plan delivery, however, with their national network, to see whether or not anything approaches to what they have with the PCP 360 or their PCPCH coverage benefit. And if there was something, then over time we could move to that. Hopefully that's understandable. What we're basically saying for both of the member-driven ones is not anything now, but to see whether or not there's something more behind the request around the reduction surgery, and to look and see whether or not there's developments at the national level that would look more like a coordinated care model that we could then consider. The last topic where we spent an hour was listening to Kaiser Permanente's behavioral health. It was described as an access report, but actually talked about strategies that they have in place to meet the crisis. I could spend 20 minutes going through what I thought were some pretty amazing and innovative ideas. However, I'm going to try to focus a little bit. The idea of self-care, primary care, and specialty care, with the coordination that occurs between all of those. Probably the biggest change that's happening is something called behavioral health consultants that the organization has dabbled in over the years, but is now committed to fully implementing, and it involves putting in a behavioral health consultant, a licensed counselor, therapist in all of the primary care settings, family medicine, internal medicine, and pediatrics, at a goal of 1 to 10,000 members served. They think they'll get there by 2023, and that will greatly support, one, primary care, but also have very rapid access to people. The idea of these consultants is that they would see patients for 1 to 4 visits, but would be available within sometimes same day, or at least within a couple days. In terms of utilization, mental health admits are stable and equal to Kaiser's book of business. Outpatient, it's increased for OEB 30 to 40% over the past 2 years. And for mental health, it's increased, it's above the book of business. Interestingly, spouses, there was about a 10% increase in utilization. Adolescents and children, a 30%. Employees, 40% increase in outpatient utilization. Same increase with outpatient substance abuse issues. Access, we discussed that there's been word that Kaiser Permanente has wait lists for their in mental health. However, many of those were basically things like a person requesting transfer to a different location, a second opinion, waiting for residential substance abuse treatment, where it was in the 1 to 2 weeks, where we were told that the community it's about a 6-week wait. And for intense outpatient programs, they start basically every 2 weeks. So if someone missed the start of a program, they're automatically going to be on a wait list for 13 days before that starts up again. The final issue had to do with specific access numbers for routine mental health triage. The target is 14 days. They made that all but 2 of the 11 months of 2021 that they reported. They did not have December data. For urgent mental health therapy, the target is 2 days. They made that all but 1 month. That month it was 3.1 days for it. They're around quality, 6 of 8 quality measures, they're in greater than the 90th percentile, and 7 out of 8, they're greater than the 75th percentile. So in general, we were, and a very interesting finding that they had was there was a greater utilization of these primary care-based behavioral health consultants, higher percentage of BIPOC population than seen by other members. So it's very possible that people of color feel safer and more willing to see therapists when needed, but when within a place of comfort, their primary care home. And that was, I thought, a very important finding. So I hopefully I did that within close to 10 minutes. But again, it was a very, very rich 3-hour conversation today. Any questions for me or additional comments from other CL members?
Pretty comprehensive, Tom.
Okay.
Yeah. All right, so we're going to move on to IWG. I have to go pick up a stranded daughter, so JJ, can you finish this meeting out?
Absolutely.
Okay?
Yes, sir.
Okay, sorry about that. It's minor emergency, so.
I'm happy to take over the last 3 minutes.
Well, fortunately, the IWG report's fairly short because most of what we talked about at the last meeting was presented today, both in CL and in the board meeting. So we did talk about behavioral health and developments and recommended changes for the coming year. You heard that today. We talked about the hospital cap. You just got that presentation. And we also talked about the COE program. And what was interesting in our meeting was that we had presentations and recommendations from the 3 carriers involved with our 2 boards. And I could describe it as a tale of 3 carriers because each one had their own distinct approach as to how they would go about presenting it. Kaiser did a very nice job of explaining how they approach musculoskeletal procedures between their various facilities and how they measure success with their surgeons. So they gave us the whole enchilada in terms of how they approach it and how they would handle it as far as MSK goes. I guess the next on the continuum would be Providence, where they own a number of the facilities and have their own medical practices, they were not as supportive of our pursuit of a distinct COE program, stating that they felt they could do the job within their system. While they were willing to continue cooperating with us, they were not, they were suggesting it really wouldn't make that much difference to get to the bottom line. That was kind of disappointing. And then the most open system being Moda, you got the latest update today in terms of how they're going about developing a comprehensive program within an open system, and their commitment to doing their best to have a program up and running in the state-based program, representing and having access in the various regions of the state. And the only caveat on their program, they're pretty confident they can have this completed, is just the impact of COVID, which, you know, that's changing every day at this particular point. So a productive meeting, but again, just showing how challenging it is to put together a new program in a state as varied geographically and in population density as Oregon is. And generally, I think we're making good progress and we're serving our members well in our pursuit. Any questions?
Yeah, this is Tom. I'm sorry I wasn't able to make that meeting, but you know, I'm because this issue of Centers of Excellence became IWG topic, does it mean that we have to wait for IWG to move forward with Centers of Excellence for OEBB members? And I'm not expecting an answer right now, but I'm throwing that out as an issue.
We could proceed as a pilot project.
Ah, the infamous pilot project.
There you go.
Perfect.
Am I making you uncomfortable, Ollie?
Yes. No, I mean, I think there's going to need to be some coordination in how we navigate that. And,
yeah,
you know, I don't know that, you know, OEBB's any further out front, you know, to really have a completely different kind of pilot project. But, you know, we'll see in a few months as it plays out.
Yeah. Any other questions? Okay, JJ, I think you get to finish right on the dot if there's no public comment.
Rose, do we have any public comments?
No public comment.
All right, well, with that, thank you, everybody, and we are adjourned.
Thank you all.
Thank you.
Thank you.
Bye-bye.